Good morning and welcome, everyone. I'm calling the 444th Council meeting to order. Welcome and thank you for joining us today. Just a quick reminder, Council members, please have your video on during the meeting and mute yourself when you are not speaking. And to all, we are live streaming this meeting through the RCDSO's YouTube channel so that members of the public, profession, and other interested parties can watch our proceedings. And I will remind you of this during the meeting, but again, just a quick reminder to use your Zoom hand, so raise your hand function when either asking to be put on the speakers list or when to vote. And at this point in time, I would like to turn to the land acknowledgement as the official opening of our meeting. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to teach each other and this land that we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace the role we play in regulating dentists, in protecting the public interest, and in strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. And at this point in time, I'm going to turn it over to Dan to do the roll call for council.
Thank you, Hanno, and good morning, council. I will do the roll call in alphabetical order, so please be ready to unmute. Nalan Bhargava.
Present.
David Bishop has sent regrets. Amelia Chan.
Present.
Ram Chopra. James Colliver.
Present.
Christina Cordero.
Present. Present.
Christina's there. I see her. Her hand's up. Peter Delane.
Present.
Nancy DeSanto.
Present.
Mark Eckler. Ellie Fisher.
Present.
Please there. Noha Goma.
Present.
Daniel Haas.
Present.
Vivian Hugh.
Present.
Nizar Ledak.
Present.
Anthony Licio.
Present.
Anthony Mayer. Harinder Sandhu.
Present.
Ryan Smith.
Present.
Osama Solomon.
Present.
Robin Somerville.
Present.
Robin.
Present.
Thank you, Robin. Rod Stapleforth.
Present.
Mark Trudell.
Present.
Aaron Walker.
Present.
Judy Wilikovich has sent regrets. Deborah Wilson.
Present.
Thank you very much. Back to you, Hanno.
Thank you. And at this point in time, I'd like to ask Dr. Harinder Sandhu to provide the president's remarks. Harinder, please.
Thank you, Hanno, and good morning, everyone. I would like to begin by noting that 10 days from now, September 30th, is the National Day for Truth and Reconciliation in Canada. Though part of our history, the impact continues through generations. There will be events and commemorations and memory to honor survivors and their families. The college is closed on this day to remember the history and legacy of residential schools. I would like now to welcome you to our second in-person meeting of 2024. Thank you, Council, for your feedback in regard to the June meeting. Many of you noted that it is valuable to have meetings in person. Though it can be easier to meet virtually, I know that all of us who are able to attend benefit greatly from the opportunity to have in-person conversations. As always, many of you request more time to discuss key issues. This is a very fair and important point. We will continue to incorporate more time for discussion into every agenda item. I personally appreciate your honesty and your feedback. Thanks to your input, we work to improve every meeting. Even though we have a full day of presentations and discussions, we have a very full agenda ahead of us as well. I would like to highlight a few topics as we launch our day. The Canada Dental Care Plan continues to make news. You may have heard that in early August, the Minister of Health, Mark Holland, announced that over 75% of oral health professionals are participating in the program. This included approximately 70% of all dentists in Canada. According to a recent report on CBC, the rate in Ontario is above average at 77%. This is a great news for patients. And I just heard from ODA, they have actually validated the same kind of figures as well. Earlier this month, Health Canada reported that 650,000 patients have been seen. In Ontario, over 250,000 patients have been to the dentist. As we have discussed before, this program is transformative for oral health care. It will evolve and it will improve over time. We have several significant matters before us today, and I do want to highlight a few items. When we first began to explore the work that would be involved in modernizing our standards, we knew it would represent considerable work. I must tell you that at the beginning, I had my doubts because I have been part of many working groups before. I have been involved in previous work to update standards. It was cumbersome, difficult, and took for too long. I think it is truly amazing, collaborative, through and focused on the final product. This work is so important to the day-to-day practice of the profession. It must be methodical, scientific, researched, and discussed. Council, you are part of this process. Your input is so valuable. I just want to underline for you how remarkable this work is. I know that this is going to go out for feedback, and I encourage all of you to also provide your comments to these standards. Thank you again to terrific team of professionals, Cameron, Shivani, Danny, Sarah, Alex, and Michelle. And of course, Andrea Forti. The second item I want to highlight is the Equity, Diversity, and Inclusion Report and Statement. Michelle Tremblay and Nizar Ladakh will be working you through the work that we and the college have accomplished over the past several years. ED is not a project that has a beginning, a middle, and an end. It is work that we do on a daily basis to make our work, our profession, our community more inclusive. We have made very strong progress so far, and I hope it inspires all of us to continue our leadership. Also in your package today is a brief update on the PLP divestment project. We heard from our consultants in June, and we will continue to report to you, to the profession and the PLP staff. There may be times in the process where we, for competitive and privacy reasons, we may not be able to update you, but you will be kept informed of all the key milestones. On a personal note, I would like to highlight a note that was in the consent agenda, the reappointment of public member Jamie Colliver. And congratulations, Jamie. Thank you so much for your contribution and your hard work. Let's give him a hand, please. And especially your work on Professional Liability Program Committee. Your insight and guidance have been critical these past 2 years. We are delighted that you will continue to serve for 3 more years. And one last note, I would like to recognize all the work it takes to get us together. It truly is more work to meet in person. Thanks to everyone involved in helping to get us ready today and for making this meeting run smoothly. Your professionalism makes it easier to do our work. I would like to make special mention of Dan, the senior leadership team, and the entire staff of RCDSO. I want to thank you for all the work that you do every day for the patients of Ontario. Council, I'm always honored to be in your presence. You bring thought and wisdom to every conversation. To all of those who are joining us via YouTube, we sincerely appreciate your interest. With that, Hanno, I'll turn back to you. Thank you.
Thank you, Harinder. Next on the agenda is declaration of conflict of interest. Conflicts are important to declare because of our public interest mandate and as a standard reflected in the Ministry of Health College Performance Measurement Framework. And just a reminder, we continue to work with PricewaterhouseCoopers on the PLP divestment project. So at this point in time, I will ask if there are any members of council who feel that they have a conflict of interest, real or perceived, to declare on any of the agenda items to be discussed today. I see none. Thank you. Next, let's turn to the consent agenda. We continue to use the consent agenda as a time-saving mechanism. On the consent agenda are several items that are for council's information, acceptance, and ratification. Council will be asked to approve these in one motion. You may ask a question of clarification about an item on the consent agenda, but if you wish to have a deeper discussion about an item, we will remove it from the consent agenda and address it at the end of the meeting. I would, however, ask that the threshold is very high should you make that request. The consent agenda items are in your meeting materials starting from pages 20 to 151. Are there any questions or any other changes on the consent agenda? Seeing none, could I please have the first motion on the screen? And motion number 1 is that the following items be approved and or received for information by council. Approval of the agenda, approval of RCDSO council meeting minutes, June 20th, 2024, council evaluation survey results, June 20th, 2024, registrar and CEO report, RCDSO council work plan 2024 council education plan, financial update Q2, Office of the Fairness Commissioner status update, practice models and corporate dentistry, policy report, and reappointment of public member. And I see Ram is moving that, seconded by Christina. All in favor, please raise your virtual hand. And that is carried. Thank you very much. Next, I'm going to turn it over to Dan for the registrar and CEO's remarks. Dan, please.
Thank you, Hanno. I'm just going to share my screen. Can we see that? There we go. Great. Good morning, Council. It's great to welcome you back from a long and hopefully relaxing summer for you. I will provide you with a snapshot of some of the things that are happening in the college that we may not have as topics on the agenda for today. And I would obviously start with one of the topics that has been most prominent for the oral healthcare professions in Canada, the Canadian Dental Care Plan. And what is on the screen is complementing what our president, Dr. Sandhu, mentioned earlier, the utilization of the CDCP by dentists in Canada. And this is a graph that shows you the percentages across the different provinces that was from Health Canada data and reported in the CBC and other media outlets over the last couple of weeks. You can see that Ontario is not the highest, but has a fairly significant percentage of dentists that have submitted at least one claim to CDCP, and that's at 77%, so just over 3/4. I also want to talk a little bit about some aspects of the program. As we've mentioned, utilization continues to climb. I would say that this is the beginning of a success story, that there are patients who did not have access to oral health care who are now getting access to oral health care. You can see that over 500,000 patients have received care from the plan. So there are parts that are working, 77% of dentists in Ontario, and there are other percentages available for other health professions. Of course, there's always going to be a lot of information needs, and so Health Canada is, I was going to say planning, but I think they've actually launched ad campaigns, and there are some that you can access on YouTube. They will be on television, streaming services, all sorts of different ways to promote the CDCP, and particularly with respect to individuals who are under the age of 18 years. There's always going to be hiccups and emerging issues with a plan of this nature and scope. And a couple of them are listed at the bottom of the slide that there was a media report recently of the impact in one of the faculties of dentistry across in another province that is having some difficulty now in terms of the patient load in their training clinics. And so that was something that was recognized at the beginning and is something that we'll have to keep an eye on and make sure that there's a way to balance this increased access for patients, and also ensuring that our students and trainees get the kind of experiences that they require. There are issues that relate to Sun Life delisting dentists, and we, with the ODA, are trying to understand some of the rationale and reasons why dentists are being delisted. I'm not going to say that it's a large number, but there are some who are not able to submit claims through CDCP. So right now it's an information gathering phase to try to understand the rationale by which Sun Life is making those decisions, and also any appeals process and what that will look like for those dentists who are affected. And finally, you've heard about compliance verifications or the on-site audits that are a part of a multi-step process to ensure that claims are valid and accurately reflect the services provided. And we are working with and starting to work with Health Canada to really design where the regulator will be involved in those on-site audit procedures. So again, lots of things to be grateful for in terms of the success of the program, particularly with respect to access, and also, as expected, a number of elements that still need to be worked on. I'll turn now to governance and regulatory and the landscape within that. I'll talk a bit about the national level. There's active ongoing work that you've heard about before to build alternative pathways for internationally trained dentists, or ITDs, in the country. The faculties of dentistry, the ACFD, are working on a gap assessment and training program that will accelerate this process for some candidates who are close to the Canadian standard. The national examination body, the NDEB, is looking at changes to its equivalency process, and that's a series of 3 exams at this moment that are required for ITDs to successfully complete. And there are obviously lots of timelines and issues that are related to that. And the NDEB is looking at those examinations and the blueprints. They're looking at the timelines to see if there are ways to better streamline and better provide capacity for individuals with exam seats. And the NDEB is also engaging with the internationally trained dentist community to try to understand what their experiences are, and can they use those experiences to make changes, but still to maintain the rigor of the examinations. There is a new CEO at CDAC, which is the accreditation body in Canada that accredits dental faculties, but also dental hygiene programs and dental assistant programs. There is work underway with that new CEO to really look at modernizing the organization. A strategic plan is almost complete. They are engaging more with partners. I've talked at this table about how we provide a significant amount of grant funding to this organization and have not really had a voice with this organization, and they are really looking at that much more significantly now. And also addressing some of the issues that I've raised with this table and with CDAC as well, that relate to transparency of accreditation reports and the funding formula itself for more equity and fairness within that formula. So all of that is shaping up, and I will certainly report back to you and the executive committee. And finally, the NDEB is looking at a national credentials repository. And what that would mean is that individuals who are looking to be licensed in Canada would submit their credentials to one body, they'd be adjudicated, and they'd be used multiple times. So there's a lot of streamlining opportunities that could be available. And this is, I call this a trust building exercise. All the dental regulatory authorities need to know that what the NDEB does to look at the credentials and adjudicate those credentials is acceptable to the regulatory authorities. And then we'll really be able to start to be more efficient in those processes across the country. So again, that is a huge multi-year project, but something that I think is very exciting and holds a lot of opportunity for the system. In Ontario, we know that the current government's priorities are access to care and scope expansion. We've seen a lot, you've seen a lot, I'm sure, in the media as well, of scope expansion for pharmacists. So there are things that are being looked at currently and consulted on for the pharmacy profession. I've also just flagged for your attention some work that's happening with the Ontario College of Pharmacists that continues to tackle those system influences or those things that interfere with professional and clinical judgment. And those might relate to corporate ownership and they might relate to insurance carriers. The government is consulting now on what's called preferred provider networks, where patients don't have a choice from an insurance carrier perspective in terms of where they will receive their medications. And they're looking to see with the Ontario College of Pharmacists if there are any solutions, either legislative or otherwise. I think this is a really important topic that we are watching very carefully, and I'm talking to my counterparts all the time. As we have a strategic project around practice models and corporatization. You have a briefing note in your package today in the consent agenda, but we will be spending a lot more time on this issue in October and December. There's been a lot of work that's done to really gather the research and the evidence in the environmental scan. And we want to start bringing that forward to you to really start talking about our issues, the benefits, the risks, and also the options for recommendations. So more to come on that. And finally, on this slide, there is a regulatory table that's been created to look at infection prevention and control by the Chief Medical Officer of Health. So Dr. Helene Goldberg, who's on staff at the college, is our representative, and it has a number of regulators who deal with IPAC issues with their professions on a regular basis, looking to really make sure that the provincial guidance is evidence-based and to make sure that there are ways to educate professions through the colleges and otherwise. So again, a very positive development coming out of the pandemic, obviously, and some of the concerns that were raised about the various source documents that were available and may have conflicted with each other and may not have been as evidence informed as we would have liked them to have been. With respect to accountability for registration, I've mentioned before that we meet regularly, quarterly, with the Ministry of Health and the Fairness Commissioner. And this is to ensure that our registration data is meeting the legislative requirements. But I think most importantly, they are very interested in the work happening at the national level. And the internationally trained dentist community has raised issues over the last 3 years or more. And the Fairness Commissioner and the Ministry of Health are really interested in how we are working with our national counterparts like the NDEB. So they spend time talking to us about our timelines, which we meet and exceed every quarter and have for the last year or more, our timelines legislatively. So that's terrific news. They want to hear about the changes that are underway by the NDEB, and that's something that we provide on a regular basis. And recently, 2 days ago, we talked to them about some regulation amendments that we are going to be seeking, and likely on a fairly quick basis. And that relates to the decision by this council to divest the PLP program, where we will have to have some minor regulatory amendments made to ensure that all dentists maintain professional liability insurance. So that work is ongoing, and you'll hear more about that as well, because for regulations, you need to approve the regulations. So that will come back to you in the next few months as well. And we also talked to them on a very preliminary basis about some project funding. I will tie this together near the end of the meeting when I talk a bit more about the Oral Health Access Fund that is also a briefing material in your document. I want to note, and this is something that was fairly prominent this week, on September 18th, 2 days ago, the Canadian Medical Association apologized for past and present harms to that the medical profession has been a part of with First Nation, Inuit, and Métis peoples. They are taking ownership, as they've said, for the CMA's history, and they are working now with a real strong commitment, a transparent commitment to rebuild that relationship. This is very significant. I think this is something that we have seen. We've seen some of the system partners in British Columbia who have done something similar. We've certainly spent a lot of time with Indigenous training programs and training around reconciliation last year and onward. And I think it's just something that I wanted to note for you, and we are paying careful attention to these acts. In terms of partners and collaborators, I thought I would tie a few things together for you. We have very active programs in continuing education and professional development. You also know, you hear from us regularly about our work in access to care and equity, diversity, and inclusion. And I just wanted to point out that there's some real exciting work happening through our quality assurance program. So kudos to Nancy DeSanto, Dan Haas, and others who I don't know the full membership of the QA committee, but there's some real work that has emerged to think about education for the profession and be creative in terms of what that education looks like and where it's coming from and who's able to sponsor and ensure that credits are valid and available to the profession. So of note, in September, a couple of days ago, Rainbow Health was approved, Rainbow Health Ontario, as an approved sponsor for CE education. And this is an organization that really supports education for healthcare practitioners who are servicing individuals from the if I try to do this off the top of my head, two SLGBTQ communities. And I wanted to note this because this is also tied together with the decision back in March to approve Special Olympics Ontario as an approved sponsor. What this does is it opens up the door for different types of training for dentists who are able to service populations that have not necessarily received or achieved the kind of oral healthcare services that they need. And so this is, I think, a real special acknowledgement that we have some work to do within the profession, and also a creative approach by this college to make sure that education is not just clinical education. It is about cultural competence and sensitivity to the various populations that dentists serve. On another note, I wanted to point out that we are developing, and I think we have completed the development of joint statements by RCDSO and by the College of Physicians and Surgeons of Ontario. We hear concerns quite frequently from dentists who are trying to coordinate care with primary care physicians. And we have developed some work and some ways to communicate better with both professions about how to best achieve interprofessional care in this domain. And really looking at how dentists can approach physicians in terms of the kind of information that they need to provide appropriate care to a patient that will be either in the chair or receiving service in the future. And so these statements are going to be critical to support dentists in terms of how to navigate that relationship, and also by working with the CPSO to ensure that physicians are also looking at the critical role of dentists in oral healthcare and how they can support that with particular patients, and focusing on risk assessment for patients who are receiving oral healthcare services. There's also some work that's happened, and this goes back, I think, to June with the registered dental technologists. This is related to the dental technologists have for a number of years had a stamp that really authenticates that the work that has been done by a validated dental technologist or a registered dental technologist. The CDTO, the College of Dental Technologists of Ontario, has replaced this now with more digitized and modern ways to ensure that validity. So we've communicated, and will communicate in an upcoming newsletter with dentists, that they still need to verify that the chosen lab has a registered dental technologist, and that the registered dental technologist is validated with the college, the CDTO. But it won't necessarily be in the form of a stamp. There are different ways to do that and to do that validation. So information will be coming out to the profession in the upcoming newsletter. Quickly around the college, I want to just mention, and there will be a presentation in one of the next two meetings, just on the project that we have around service experience. And I mean that very broadly, that as a public organization, we take that role very seriously. We want to ensure that anyone who is inquiring with, calling, contacting the college through whatever means is experiencing a kind of service that they deserve. And so these are just a snapshot of some areas that we've been focusing on since the last council meeting, or areas that have been achieved since the last council meeting. We now have our complaints process. The information materials have been translated into 11 languages, English, French, and 9 other languages. And we've based that on some evidence that we've collected about the most common languages either contacting us or prominent in Ontario. We've had through the PCRA, the Professional Conduct and Regulatory Affairs area, look at over 500 pieces of correspondence that go out in various parts of the process. And they have not only reduced those dramatically, but they've changed all of the templates so that it's more plain language. I think one of the common criticisms we have is that they're too legalese. And so we've really tried to put that into a plain language form because many of the partners through PCRA are patients and members of the public. And finally, for you, council and committees, we've had a pilot where we've provided extended service through our IT area. So if you're reviewing your materials in the evening or on the weekend and you're having some IT difficulties, our team will be available to you. That project has been very successful through Aldwin's leadership and the team's enthusiasm. We are extending that to staff as well. But you can see that the hours that are available, we can't do 24/7. We don't have the capacity for that. But we do have extended hours that we will continue with and provide that service to you. I also want to comment on the RCDSO portal. This is the portal for members, for dentists. One of the things, or many of the things that I heard when I first started in my first couple of years was a real frustration with the portal that dentists go to renew their sedation authorizations, to change their addresses. A real frustration with many different aspects of that. We have recently launched, just about a week or so ago, or a couple of weeks, the new portal, the revised portal. It has a very different feel to it. It's very easy to navigate. There's some very critical pieces that are on the front page when you enter the portal. So we are going to gather feedback from dentists. We've based the changes on lots of feedback that we got from 2 annual renewals, where we asked the questions in the survey and had literally thousands of comments. Not thousands of themes, but thousands of comments. And we will monitor this carefully, and any feedback from you, dentists around this table, or the profession, we're more than happy to hear. And as Susan Taylor has said, we've made it easy and we want to make it easier. So we will keep working hard to make sure that this is working and doesn't put a roadblock in front of dentists. High volume summer for registration. We had approximately 200 new certificates of registration that were issued in June, and this is more than double a typical month. So it's usually a busy part of the year, but the volumes are huge. We also had 9,000 health profession corporation certificates of authorization that were renewed over the summer from June to August. Another really interesting part of our work is, as of yesterday, we have within the investigative area on our website, there's a section that relates to how do we address issues of bias in our own programs. This is really important for us to do as a public interest adjudication body. And so the content is up, and I would encourage you to take a look at it, and we can help you find it as well if you can't. And really to ensure that the public and the profession is aware that we have legislative responsibilities. We have to practice due diligence and rigor in our processes. We have to be impartial, and we also have to eliminate or at least mitigate bias within our processes through the investigations all the way up to the committees that review materials and make decisions. So we've tried to provide that information to the public and the profession to make sure that they're aware of the steps that we take to ensure that. And finally, I will just mention, and it was in my written report, that we had a really fantastic live in-person RCDSO Connect event in London. I believe it was June 25th. It was the latter part of June. We had over 100 people come out. These were dentists, faculty, students, members of the public. We had Mark Trudell, we had Aaron, we had Harinder. Just a really fantastic way to engage with the community. We got some very good feedback. We had sessions that were designed to look at access to care and get feedback, and you'll hear more about that later today. And there will be a write-up in our RCDSO newsletter, which is coming out in the next few days as well. So I thank you for your attention. I'm prepared to take any questions, and that hopefully gives you just a little flavor of some of the things that we were working on over the summer.
Thank you, Dan. And we do have a few moments for council for questions of the registrar's report. Ram?
Hello. Dan, as you know, we have approved the emergency class of. Do we have to wait for provincial government to start that program, or do we have the authority of the council to start that process of emergency registration?
Are you referring to the program that we're seeking funding for under the Oral Health Access Fund, or the professional liability regulation amendments that I mentioned? I want to clarify.
No, the emergency class of registration.
Yes. Yeah. So Ram, I think that design was for an emergency that needs to be declared by either the Ministry of Health, the Minister of Health, or the Council of the College. So there are very specific thresholds and criteria to use to launch that. So we have not done that to date. There is not an emergency at this point in terms of launching it. There are projects that we are trying to work on, and we're trying to look at ways where registration might be different. Whether that emergency class is put into effect or not, I think it's too early to know, but it has not been launched by either this council or the Ministry of Health, if that answers your question.
Okay, thank you.
Thank you. Robin?
Yes, can you hear me okay?
Yes, we can.
Okay, thank you. Just with regards to working with physicians more closely and the relationship that you were discussing there, is there a way currently right now for physicians to bill OHIP when a dentist does a referral, whether it be, a question about needing to know medications or blood thinning before extractions? A number of things. There's always a timeline issue as well because they're so backlogged. But can they get paid for that service? Or if you are having communications about that, I would think that that's something very important to work on, because we all know the physicians are overworked at what they do with paperwork. And I feel awful when I reach out to one and make them do more paperwork if there's no way for them to bill.
Thanks, Robin. I don't know the answer to your specific question about whether physicians can bill for it or not. I'm just looking to the staff. I don't know if Leslie, you've had any conversations about this. I do think, Robin, though, the nature of your question, though, is how we continue to work with the physician, the medical profession, so that in those cases where dentists do need to have some information that will help in the oral healthcare treatment plan, that it can be available on a timely basis. And I think by working with the CPSO and trying to navigate some of the different barriers, we'll continue to do that. The statements that I mentioned are just a start, and they might at least achieve some effect. I think where some frustration rested was that dentists sometimes would ask for, broad clearance or some kind of broad statement from a doctor that the patient was okay to do whatever service or treatment, and that wasn't helpful. So it's really trying to look at a way for the question to be more specific and risk-based, and for the physician hopefully to be able to answer that in a much faster fashion than may be happening. So we will continue to work on that and look for some expertise from some different stakeholders.
Thank you. I have no other questions or no other people on my list, so I would like to move on to the next item on the agenda, please, which is an update on the Professional Liability Program Divestment Project. As you will recall, at our June meeting, Council heard an update on the divestment process for Mergers and Acquisitions Advisor, PwC. This item is for your information. The material can be found on pages 152 to 153 of your council package, and I'm going to turn it over to you, Dan, for a brief walkthrough.
Thank you. I'm going to try and find it. Okay. There's not much to say. You have most of the information within the materials. We're at a critical stage where the PricewaterhouseCoopers as our advisor has started to go out and converse with organizations. There are what we call marketing materials that are available, and they are beginning that process. So obviously you will be kept informed. It is a process right now that will have a lot of confidential features to it. There's obviously very sensitive information. Organizations that are being talked to also want to maintain their confidentiality. So that's why we've provided you with a general process update. But today is not for any more discussion because we don't have a lot more information for you than what we've provided over the last few months. Also wanted to point out that the annual renewal will start in October, so a couple of weeks, where we are obviously going out and getting the annual fee from dentists. We will continue to collect the amount of money that covers PLP for 2025, and dentists will be covered for 2025. So notwithstanding when this transaction might be finalized, dentists will have that coverage all through 2025, and as soon as we have more information, then we will be providing information to the profession about what happens in 2026. So that's where we stand at this point in time. I certainly welcome questions. There may be some or many that I'm not able to answer, but we will continue at each meeting to keep you updated, at least at a high level, if not a session where we can talk more specifically about some of the things that are happening.
Thank you, Dan. Nancy?
Thank you, Hanno. Good morning. Dan, I have a quick question. I'm not sure if you can answer it at this point in time, but what alternative methods are being considered to ensure registrants hold adequate liability insurance protection? Not sure if you can provide information.
So I can speak generally to it. I think that will be a part of any discussions with an entity that is looking to take ownership of this program. That will be a big part of the discussion. I think from what I mentioned earlier in my report, it has been for many years quite easy for us to know that every single dentist has professional liability insurance because they get it when they register. So every single dentist has it. Now we're going to be entering an era, not unlike every other college and profession, where you can have attestations, you can have audits, you can have means to have a data download from an insurance provider potentially who offers that professional liability to a mass number of members of a health profession. So there's all sorts of ways that you can ensure that the profession knows they need to hold it, audit to make sure that that's happening, and when we might find out that someone doesn't, that's where this regulation kicks in, where there is the concept of an immediate suspension, essentially, if you're not holding professional liability insurance. And that's all for public protection because you need to have active insurance in order to practice. So there's a number of steps along the way.
Thank you. I have no further questions, so I'd like to move on to item number 8 on our agenda, please. And this next item is in regard to the college's work on developing standards of practice for the dental profession. The work on standards relates to our 2023 to 2025 strategic plan. Standards represent one of the college's 6 strategic projects. Cameron Thompson, Manager, Standards and Strategy, will walk us through an update for council's information. And Cameron, at this point in time, I'm going to turn the floor over to you, please.
Thanks so much, Hanno. Just bear with me a second while I try and get my slides up. Apologies, just one more moment. Trying to get this up in presenter view. And that is not working, so hang on one second. Oh, perfect. Okay, thank you. Susan Taylor to the rescue. Thanks so much. Okay, sorry for the delay. I'll just jump right in. So thanks again for the intro, Hanno, and for the opportunity to speak with you this morning. I'm happy to be here to provide you with an update on work that's been underway within the policy team related to process modernization and standards review and development. This presentation really consolidates and updates some of the information that you would have seen as part of the policy report and the strategic dashboard within the council materials. And it will sort of pick up where I left off last summer, because some of you will recall that I delivered a similar presentation to council last June. And my focus today is going to be on sort of the advancements and milestones that have been achieved since then. So I'll just spend a few minutes reminding you of the update that I provided in 2023. I think that will set sort of a good foundation from which I can describe the new developments that have occurred over the last year. But I'll spend the bulk of the presentation describing recent milestones and new work underway related to our key areas of focus. And then I'll spend just a few minutes providing you with a preview of work that you can expect from the policy team in the near future. But I'll be covering a lot of ground in a short amount of time. And so let me know if I'm moving too quickly or if I've failed to address something you're interested in hearing about. So this slide recaps the 3 main areas of focus from my 2013 or my 2023 update. So these were standards modernization, standards prioritization, and policy recruitment, which was just getting underway at that time. And you've heard me talk about standards modernization and standards prioritization before, but just by way of reminder, standards modernization is a multifaceted and ongoing effort to revisit the college's historic approach to developing and communicating standards of practice or guidance to registrants. Really what we're trying to do is identify and incorporate best practices for standards review and development and for communicating guidance to registrants and the public. Standards prioritization is our effort to come to an informed and transparent and rigorous decision about the order in which we review, update, and develop our standards of practice. And I'll just take a few additional moments to describe each of those topics, since I think the reminder will be helpful for the rest of this update. So on the subject of modernization, this is a reminder for many of you, but as I said, what we're trying to do is sort of refresh and update the college's approach to standards review and development with an emphasis on some key goals. So consistency in our process, transparency, rigor. We want to ensure that our process is inclusive and importantly that it reflects key principles of equity, diversity, and inclusion. Everything you see on this slide was presented last summer. Many of you have heard me describe these objectives sort of in other settings. The infographic on the right side of the slide provides sort of an overarching picture of what we want to achieve for new and revised standards of practice. So we want them to be up to date and accessible, concise to the extent that it's possible. We want them to be inclusive, in other words, reflective of a variety of experiences, both for dentists and for patients. Aligned with any ministry expectations or requirements as might be set out in the college performance measurement framework, evidence-informed and scientifically rigorous, and of course accurate and comprehensive. So in reviewing, updating, and developing our standards, we want to be sure that we're being sort of comprehensive and intentional in how we reflect these things in new documents. This is also a refresher. This process was in place last June, where I described it in some detail, but this visual, which I know is a little bit busy, it's a depiction of our standards review and development process from beginning to end. So by way of reminder, very quickly, every review follows the same process or trajectory. Each review begins with the identification of or assignment of a lead analyst. Each review is typically supported by a staff clinical lead. This is usually a staff dentist who works alongside the lead analyst throughout the review. I won't describe each of these steps in detail, just in the interest of time, but sort of in an overarching way, the sequence of events is basically there's a really comprehensive early stage of research and development. There's oftentimes at the early stage public consultation where we invite feedback on an existing document or a new issue that we're exploring. There's a period of drafting and review and approvals. You'll recall that Quality Assurance Committee and Council are the two key sort of decision makers in this process. There will always be a consultation phase for new draft documents. So a document that we've updated or a new draft that we've developed, pending council's approval, of course, and ultimately revised final draft standards will be brought back to QAC and then to council for feedback and final approval as well. It's a pretty high level description of a fairly involved process. As indicated on the right side of the slide on a case-by-case basis, there are additional sort of tactics or strategy we might also employ just to be sure that we have an accurate and informed and comprehensive final document. And some of these additional tactics relate to stakeholder engagement strategies, and what's reflected on the slide includes engagement with our policy working group, subject matter specific experts, and advisory groups, and so on. On the topic of prioritization, as I said earlier, the goal here is to have a process in place that allows us to systematically review existing college guidance, which, as you know, is principally set out in standards of practice, but also practice advisories, guidelines, dispatch articles. We're sort of narrowing the scope of documents through which we communicate guidance, but that's sort of the current state of things. And this allows us to make some informed decisions about what is reviewed first. So to be a bit more concrete about it, as you've heard, there are a number of RCDSO standards and other types of guidance that are in need of review and updating, some more urgently than others. For example, some of our legacy documents haven't been updated in many years. Some have issues around currency and accuracy. There are a number of types of issues that we've identified, and it's not possible to do all of that work at once. So this helps us to make decisions about where to start. This also gives us a process that allows us to evaluate new and emerging issues. So it's not only a framework that allows us to evaluate existing documents, it allows us to review issues as well. And so this is a framework that the policy team designed with the support and approval of QAC last year. It sets out criteria essentially that inform our analysis. So for instance, we would look at considerations like errors or omissions that might have been identified in a document, or whether an emerging issue poses a potential risk to patients. And by applying this framework, we can make some decisions or propose some recommendations about which standards in our view are most urgently in need of updating. On the subject of recruitment had not yet gotten underway when I presented to council last June, but the objective of that recruitment was covered, which was to build capacity to complete urgently updated important updates to college standards. So the focus of this recruitment was to bring on additional staff to support the review and prioritization of standards, and then to review and update standards that had been identified as priorities. And so this was a recommendation that was put forward to the Finance Audit and Risk Committee last year, where we received approval to recruit 3 new senior policy analysts on 30-month contracts to work with a dedicated focus on standards of practice. And so last time I updated you, this approval was in place, but the recruitment had not yet begun. So that's sort of in a nutshell what was presented last summer. And so what's happened since then? So first of all, the recruitment is complete. As of last September, we've completed our recruitment. We had a very successful recruitment cycle. As part of that recruitment, we actually brought on four new policy staff, some of whom you will be familiar with. So in addition to the three contract senior policy analysts that were approved by FAR, we also had a policy team member depart last summer. And so this recruitment included finding a new full-time policy analyst to replace that individual who departed. And so Daniel Garindi, who's our new policy analyst, was brought on full-time to replace that staff departure. We also brought on our three new contract senior policy analysts, as you can see on the slide. They include Dr. Sarah Rydall, Shivani Sharma, who is here with me today, and Alex Wong, who all come to us with a wealth of experience and expertise. And they've proven to be excellent additions to the policy team. And as you'll see on subsequent slides, they've helped to make good progress against what was a significant backlog of policy work. So second, as of December, the prioritization analysis is complete. So I described the prioritization framework a moment ago, and we've now put that framework into practice. So, almost as soon as our new staff onboarded, we began the process of reviewing, analyzing, and scoring the college's existing guidance documents using our new framework. So between September, December, we reviewed all of the college's standards, practice advisories, and guidelines. And we also looked at a number of key emerging issues, which included, as an example, the use of artificial intelligence in dentistry. So the prioritization framework allowed us to apply a consistency to our approach. We were able to effectively, through the framework, generate a numerical score that effectively provided an indication of the urgency with which we felt a document needed to be reviewed. The higher the number, effectively, the more urgent our sense of the review. And so these would be documents, for example, where we had identified what we felt to be important errors or omissions or risk to patients. And probably not surprisingly, this was a significant amount of work, and I want to be sure that I give all credit to other members of the policy team and the other college staff who supported this work, because in essence, each document or issue that we reviewed was sort of its own miniature standards review. So it involved, a review of relevant literature, a review of the positions of other regulatory colleges, engagement with subject matter experts. We engaged with staff around the college who had relevant insight to provide, and a review of college data. So it was quite a bit of work. We wanted to move efficiently, but not sacrifice rigor. This slide, I know there's a lot of information in it, but it's a snapshot of our final assessment of each document and issue that we reviewed, essentially from highest urgency to lowest. So this represents all of RCDSO's standards, guidelines, and practice advisories, along with a handful of emerging issues. And as I said, taking this approach gave us a kind of transparent and empirical basis to make recommendations about which standards to review first. And recommendation really, I think, is the key word, because the decision ultimately was not the policy teams alone. So we'd committed as part of our process to seek the approval of the Quality Assurance Committee on our recommendations. And so in January of this year, we brought our recommendations to QAC, where they were ultimately approved. And overall, I think there was support for the process and for the analysis that we were able to bring forward. This slide is sort of a condensed version of the table I shared a moment ago. This is these are the high priority standards and the one emerging issue that was approved by QAC in January. Again, it's sort of in order based on their urgency or the score that was produced by our framework. I won't read them all sort of in the interest of time, but these were the 8 documents in one emerging issue that in our view and with QAC's agreement were considered most urgently in need of review and development. And in bringing these recommendations forward, we also felt that these 9 represented a feasible workload for the policy team over the duration of the 30-month contracts. In other words, we felt that these were reviews that we could complete or bring close to completion within the 30-month timeframe. And so with the approvals in place and a sense of next step, standards work got underway in earnest beginning in sort of January or February of this year. And at least in terms of sort of the standards component of our portfolio, that's really been the focus of the policy team over the last 6 or 7 months. And you're beginning to see with the decision items before you today, 2 new draft standards, sort of the fruits of those efforts. In total, 7 of the college's current standards and resources are now actively under review. In addition to that, there are 2 new college standards in development and a new guidance document. All told, there are around 10 new standards or guidance documents that are effectively under development, a combination of updated standards and net new documents. The additional reviews that we've prioritized but that have not yet started, we're anticipating that work will begin in the coming months or early next year. We made sort of a strategic decision that the lead analysts or members of the policy team would effectively be managing 2 reviews at a time concurrently, but that we've opted to initiate them in a staggered fashion just as a means of sort of managing time and resources. And I'd also add that you can expect that additional resources are going to accompany these documents and these reviews as they come forward. So by that, I mean patient-focused resources, FAQs, supplementary tools and documents that are going to support dentists and patients in understanding our guidance. So you'll recognize this slide as part of the council dashboard report. As you know, this standards work all anchors to or flows out of RCDSO strategic plan and the standard strategic project. And so basically this dashboard provides a visual representation of the update I just gave you. It shows you visually the current status of the main reviews that are underway. It's a good place for you to look for updates if you're curious going forward. Since last June's update, we've also reached a stage where we can begin putting our standards modernization principles into practice with respect to drafting and presenting standards of practice. So on the left side of the screen, you'll see the new virtual care standard of practice, which Council approved in December, along with its accompanying FAQ. And on the right-hand side of the screen, you'll see the 2 draft standards that are before you today for consideration for external consultation, consent to treatment, and boundaries. You'll hopefully have noticed that these documents reflect the modernization principles that we've been talking about, like use of plain language, use of executive summaries, consistent use of mandatory and permissive language. Our hope is that by presenting standards in this way, we can help to make our guidance more clear and more accessible and more effective. And so looking ahead, I want to flag for interest and sort of as a means of illustrating the pace of the work that's underway, when we're expecting some of these standards to come back to council for final approval. So I'm not talking about standards coming back to you for approval to consult. What I'm trying to illustrate is when we anticipate having final standards that are ready for consideration by council for final approval. Because as a result of the process improvements that we've been making and the addition of really capable policy staff, we've seen some acceleration in the pace of our standards work. And so what we expect, and this comes with a big disclaimer, which is that these things can be hard to predict and developments can arise unexpectedly that can affect our timelines. We are expecting that council will have an opportunity to consider for approval as many as 8 standards or new documents beginning next year. 2026, you'll see on the slide, is just to be determined, and that's because there are a number of factors that are going to determine what's possible to bring forward after 2025. But that reflects our target for the next 12 or 18 months. And we're hoping with council support and with the continued involvement of our complement of policy analysts that we'll be able to continue bringing forward a meaningful number of new and revised standards on a year-over-year basis. So this slide provides the same information in a more granular way. I know it's detailed and depending on the size of your screen, it might be hard to read, but at a glance, I think it paints a picture. So on the left-hand side, you can see 3 standards that were approved in 2023, although one, which is our COVID guidance, was technically rescinded. So those 3 reviews on the left-hand side of the slide represent legacy work that was underway and completed in 2023. There was a bit of a gap if you look sort of around Q4 2023 and Q1 2024. That was time that was devoted to recruitment and to our prioritization exercise. And then beginning in Q1 of 2024, following QAC's approval, you can see a significant number of new standards reviews immediately get underway. And if you follow the arrows to the right past September Council, which is today's meeting, you'll see when we're anticipating each of those standards to be coming back to Council for final approval. And as I mentioned, there's some margin of error there, but you can see them moving through towards the end of 2025. So there's quite a lot of new activity that got underway this year. But proceeding on those timelines, we're expecting to see many of these reviews conclude in 2025 and new reviews get underway that will carry over into 2026 and beyond. I'll just, in a few minutes, quickly provide a few other updates. The first is that we've struck a standing policy working group, what we're calling the standing policy working group, to support the policy team. This working group's been struck to consider issues, engage in discussion, and provide recommendations in support of revised guidance for the profession. Essentially, the working group is a group that's available. It's a resource that's available to the policy team to support us in advancing all of this work that I've been describing. The key benefit of the working group is that it gives us dedicated time with a group of contributors who are informed, who are engaged, more time than we would typically be able to get with a committee or even with council. Which allows us to really dive deeply into drafts, into issues, which is extremely helpful to us. The working group is comprised mainly of public and professional members of council. We're planning to meet between 4 and 5 times a year. We've had 2 meetings already this year. We have more meetings scheduled for October and then 4 scheduled for 2025. As a matter of outstanding business, and you might have seen this in the policy report, we're really working to have an equivalent number of dentist and public members within the working group to ensure a kind of balanced perspective. There's still a little bit of work going on to make sure that we can bring on a few additional public members, but we're making good progress in finding interested candidates. I did want to just take a minute specifically to highlight the current working group membership just for interest, but also as a way of thanking them for their time and effort, which is really essential to the work that we're doing. I'll also highlight briefly a refresh to the RCDSO website, just as an opportunity to flag some emphasis that the policy team is placing on the importance of external public and professional engagement. So in our view, it's not enough to just do the work. We need to communicate the work that we're doing, and we need to engage with the folks who are directly impacted by it as a means of building trust and buy-in and support. And so we've been trying to take advantage of outreach opportunities as they come up. We want to be proactive in talking transparently about our process. We recently updated the website, as you can see on the screen, to include a page that specifically talks about our standards review and development process. Comms also supported us in developing an excellent infographic that basically is an update of that arrow slide that I keep showing you, which sort of succinctly describes the steps of our standards review and development process. Thanks very much to Comms for that. But as I said, this is about promoting transparency. We believe that transparency promotes buy-in, it promotes engagement, it helps to build interest in the work that we're doing. And finally, this is my last slide. This just provides you a sort of a sense of the scope of the policy team's portfolio, which, as you know, extends beyond standards work. So you're going to keep continuing to hear from us about standards review and development as standards sort of reach sort of the approvals phases. You'll see drafts for approval for consultation and for final approval. We'll also continue to undertake public consultations on standards that are under review. There are actually 2 active consultations underway right now, one related to implant dentistry, one related to maintaining dentist-patient relationships. So for those of you who haven't had an opportunity to comment, I'd invite you to. But in addition to that, we also have responsibilities related to the college's performance measurement framework report. And so work will be getting underway in the near future in anticipation of next year's report. And we have a role to play in relation to RCDSO's strategic plan, both in terms of managing some of the strategic projects, but also supporting the college organizationally in developing the next strategic plan. As you know, the current strat plan will be concluding at the end of next year. And so with all that work underway, you'll likely be hearing a lot more from us at upcoming meetings. But that provides a snapshot, I think, of some of the work that's underway within the policy team and a bit of an update on what we've been doing over the past year. And so I'll stop sharing my screen and I'm happy to take questions if there are any.
Thank you very much, Cameron. First speaker on my list is Peter.
Thank you, Cameron. Just wonder, I know that we hired people under contracts. I know the work is going to go beyond the contracts. do you anticipate having to hire either more people or try to keep these people on, perhaps extending the contracts at some point?
I would say that I haven't been involved in conversations yet about sort of what will occur sort of beyond sort of the early months of 2026. But I would say that, you know, the work that we've done to date has only been possible as a result of the contributions of the new team members that we were able to recruit. And so I think there is a conversation to be had about the pace of work that we want to sustain beyond the end of 2025.
Thank you. Daniel?
Yes, thank you. And Cameron, thank you for that explanation. It was very helpful. My question has to do with the use of subject matter experts, and it may have been on the slide, but I couldn't quite see it. I'm thinking for the 3 standards you're about to start, I think it's CT scanners, opioids, and sedation anesthesia. When and how are you going to make use of subject matter experts? Will you create a small subcommittee to work with the policy group, or I'm just not clear how you'll get that information?
It's a great question, and it's a really important question. It's actually something that we on the policy team are sort of currently grappling with. So in some cases, there are like obvious candidates, like we've worked previously with subject matter experts, or in relation to a particular topic or issue, there are just sort of commonly acknowledged subject matter experts, but that isn't always the case. And so with respect to the reviews that are getting underway, there are sort of conversations happening sort of within the policy team, with the staff clinical leads, and even to some degree with the standing policy working group to try and narrow in on who those individuals are and how we might engage with them. And so it's not a very fulsome answer because we don't have sort of a fulsome process in place yet. I think historically, our engagement with subject matter experts organizationally has been pretty ad hoc. It might continue to be somewhat ad hoc, but we'd like to have more of a sort of defined framework about it so that we're sort of, those principles of transparency and accountability carry over into who we engage with and how we engage with them. But if anyone has suggestions, we are always open to them.
Okay, because I think this aspect is quite important in the development, and especially early on. And I think even before it comes to QA, the Quality Assurance Committee, I think you would need that input so that there'll be less rework later on. And I think you try to get it as right as possible early in the process. So with these 3 coming up, I believe subject matter expert input would be very important.
I appreciate that.
Thank you. Jamie?
Cameron, thank you very much. You've accomplished a lot, and it looks like you're partway down the journey. Question on one of your bullets, very last bullet on one page, public polling. Now, how do you intend to do that? What is the reason for that? Is it going to be pre-announcement of standards, post-announcement of standards? I'm just curious about public polling.
I mean, within the policy team, we haven't done, I think, any formal public polling yet. Public polling is something that I think historically has been done and is currently being contemplated with a sort of formal polling firm. Like it's a more sort of substantive process that requires some external subject matter expertise. I think Andrea came off mute, so I'll give her an opportunity to respond. I'll maybe just add as a final thought. Oftentimes the benefit of public polling is that it allows you to gain a representative picture of respondents' feelings about things in a way that you can't get from voluntary sort of subject-specific consultation. So for all our efforts to engage with our stakeholders and to have transparent, fulsome consultations, you can never confidently infer from consultation feedback involving a very small subset of people what larger populations or demographic groups might think about the issues. And so where polling, I think, is especially helpful is when you really feel that it's important to be able to say with confidence, this is what patients think, this is what the public thinks, this is what dentists think. That's what formal public polling allows, but I'll allow Andre to jump in.
Yeah, great. Thanks, Cam. And thanks for the question, Jamie. I'll just add a little bit. We haven't at this college used polling to date. So it's something that we are exploring. You're going to hear a little bit later in Michelle Cabrera-Gali's presentation on access to care. So we are using it to support that work. The timelines that you were asking about, you can do either in development, you could do it after you have a draft. I think there's different options. What we're contemplating for that project is to use the polling as we're building drafts so that we can have, as Cameron said, it's such a unique opportunity to get feedback from where you have it weighted with different demographics across the province. And the polling companies will allow us to infer that the results we have represent the Ontario public, which is such a great tool. So we're right in the process of doing that now. We're exploring it. I don't have timelines for you, but we're expecting to have that work completed by the end of this calendar year. And again, that's for access to care. We haven't used it beyond that yet. We'll see. This will be our first foray. I've used it previously in a different job, and it was incredibly helpful.
Thank you. Osama?
Thanks for the presentation. Quick question. So for emerging issue or emerging standardized standardizations, I think you had mentioned something about cosmetic dentistry or Botox related procedures. How are you guys consistently assessing emerging issues related to from a prioritization standpoint?
So I would say, I mean, we've had in some sense maybe a limited opportunity to evaluate emerging issues within the prioritization exercise that we undertook between September and December. There were 4 or 5 emerging issues that we looked at. And these were emerging issues that were on our radar that had been flagged for us by staff or by committee members. So we kind of came into that prioritization exercise with this short list of issues that we knew we wanted to look at. We didn't want to leave out of the prioritization exercise, but we also sort of weren't under the illusion that it was a sort of comprehensive list of every important emerging issue. We approached evaluating those emerging issues in the same way we approached evaluating documents effectively. So using the prioritization tool, we looked at the literature, we talked to subject matter experts where we needed to. We looked at what other regulators were doing. We considered risk to patients and so on. So that was the approach we took. I think that the framework that we applied to evaluating emerging issues as part of that exercise last fall worked well. I think there's a sort of separate question, and maybe I'm reading into your comment, Osama, but I think what I heard you ask is, what's the process going forward for sort of identifying emerging issues, right? Like by their nature, they're not always obvious or at the forefront. I think that's a little bit sort of to be determined, to sort of by as a natural consequence of the work that we do, things come onto our radar pretty frequently that are relatively new, but I do think that it will be important to have sort of a systematic approach in place to monitoring the landscape for new issues that we want to be looking at. Does that answer your question?
Yes, it does. Yeah. And in just a quick comment too, like I think, something to consider as well is, there may be new emerging issues that end up becoming very, very important. And so how are those, managed delicately, going forward, and where do they fit in the prioritization scheme in general? Something to think, because I think we were looking at all of the standardization practice, but anything new that comes up, like what's the structure in terms of the process for that?
Thank you. I have 2 speakers left on my list. The first one is Rod.
Can you hear me okay?
Yes, we can.
Cameron, thorough process. Thank you. And this may have already been alluded to, and pardon me if it had. To what extent does the process involve your coordinating with other provincial and/or national bodies, perhaps in an attempt to determine what best of breed standards are out there?
So we certainly look at what others are saying about, every issue we review. The jurisdictional review component of our process is pretty intensive. So we are absolutely looking at what others are saying. So other regulatory colleges, other regulated professions, associations, and so on. So we cast a pretty wide net. In terms of direct engagement, I would say to date, direct engagement was really only occurring where we have identified a specific need. So it tends to be somewhat ad hoc. So we might reach out to another college to talk to staff about an approach that they took or an issue that they've been dealing with. It isn't often more specific than that or more tailored than that, except in relation to sort of a handful of specific issues that will sometimes arise within the landscape that sort of bring stakeholders together. So IPAC is an example where there's sort of mutual interest and mutual impacts related to infection prevention and control measures. And there's certain sort of activities that are going away within the sector more broadly in relation to that issue. Dan alluded to some of them in his comments. There's also work that we've been trying to, or sort of a spirit that we've been trying to advance amongst the regulatory oral health colleges in Ontario to work together more collaboratively. So we're looking for opportunities to collaborate. That's very much in keeping with sort of the spirit of how we want to do this work. But to date, it happens, I would say, on sort of a somewhat as needed basis.
Thank you. And last speaker on my list is Mark Trudell.
Cameron, kudos to you and your team. Well done. Great level of effort and great progress. Thank you. The question, I'm reflecting on this proposed standards, the nature of those standards, and I'm left with the impression that there may be legal implications that arise through the development and implementation of those standards. So my question is the plan to have those standards in draft format reviewed by legal counsel as part and parcel before they are presented to council? And secondly, is there another regulatory body such as at a provincial level, the Ministry of Health, that there's a requirement to vet these standards through before the draft is finalized?
Sorry, Mark, I don't think I heard just this second part of your question, just the last sentence.
Is there a requirement, I apologize, is there a requirement that the standards also be vetted by the Ministry of Health or another at a provincial level regulatory body prior to finalizing the draft standards? The first part of the question you heard, it was in regards to vetting it by legal counsel.
Yeah, thanks so much for that. So I'll start with the second part of the question because maybe it's a bit easier to answer. I mean, certainly we cast our net very widely in terms of our consultation efforts. So we try and make every stakeholder who might be interested in or impacted by our work aware that it's happening. There's no requirement that I'm aware of for the ministry or any other sort of government agency to review the work in advance. So we certainly are very public and transparent that the work is happening, but we don't specifically send it out in that way. In terms of legal review, there isn't currently a, I don't think, sort of formal process for each document to be reviewed by legal counsel prior to council meetings. Like certainly, Alan has an opportunity to see the materials within the council meeting package. We are very sort of proactive and sensitive to issues that have legal implications that might be unclear to us, and we'll reach out proactively for advice in those cases. That's a little bit different, I think, than having every document reviewed on sort of a standardized basis. But we do watch very carefully for uncertain legal areas, and we would absolutely seek to clarify those areas before we brought something forward to council.
Thank you.
Dan?
Just to add to the part of your question, Mark, that dealt with who approves, it's actually a requirement in our legislation that colleges will develop, establish, and maintain standards of practice for the profession. So we approve with all the consultation and input that we get from others.
Hanno, if you don't mind, if I just add, Mark, I wanted to just flesh out your question about the legal review. I wanted to just let council know that on the policy team, Cameron's team, we do have a couple of lawyers. And then I also have an opportunity to oversee that work. And I'm a lawyer, as many of you know. So we do have some in-house expertise. And then we also will consult even in advance of council meetings with Alan or his colleagues, should we need it. But it's not a requirement to do so.
Right. That's reassuring. Thanks, Andrea.
Thank you again, Cameron. Thank you, council, and thank you also to the responses that we got from staff for that presentation. At this point in time, we are going to take a brief 15-minute break. So we will reconvene at 10:47 for a 15-minute break. And if you could please turn off your cameras while we break, that would be very helpful. So we'll see you in 15 minutes. Thank you. Item number 9 on the agenda continues the work on standards that Cameron outlined to us before the break. This item concerns the practice advisory on consent to treatment. The material in your package that covers this can be found from pages 154 to 170. This item will be for council's decision. And I'm going to turn it back over to Cameron, who will continue to present and will walk council through this material. Cameron, please.
Thanks so much, Hanno. And no slides for this presentation, which I think will be brief, and you won't have to watch me struggle. So as you heard, Our decision our discussion and your decision is supported by a briefing note, which you'll find in your materials. It includes a draft standard on consent to treatment, which is an appendix to the briefing note. I'll try to keep my introduction brief and not repeat too much of what's in the note. I think this note is relatively straightforward. There isn't sort of a substantive background that I wanted to provide. I will highlight some of the key details just to help inform your decision in our discussion. So the draft standard, consent to treatment, it updates the college's current practice advisory on consent, which is entitled Informed Consent Issues, including communication with minors and other patients who may be incapable of providing consent. So this is one of the college's older practice advisories. And based on that title alone, you can probably sense it doesn't cover all of the sort of key issues related to obtaining consent to treatment. It's somewhat narrowly focused on obtaining consent from minors and incapable patients. So this practice advisory was identified by the policy team as part of the prioritization exercise as a document requiring a more urgent update just to ensure that it's comprehensive and accurate. Sort of a summary of the key shortcomings of the current practice advisory is set on page 2 of the briefing note. So the draft standard updates the current practice advisory to set out legal, professional, and ethical obligations that apply to dentists when obtaining consent to treatment. In other words, the draft sets out more comprehensive guidance on this topic. So dentist obligations when obtaining consent to treatment are primarily set out in legislation, specifically the Healthcare Consent Act, and much of the draft standard is really about reflecting or articulating those legislative requirements. So beginning on page 3 of the briefing note, you'll see some of the steps that we took to develop the new draft. I won't repeat them in the interest of time, but I will point out that this was an expedited review. And by that, I mean we moved a little more quickly than usual to update the current practice advisory because of the issues that we had identified with it, and because the standard is informed, as I said, primarily by legislative requirements rather than sort of matters that were more open to differences of opinion. So the key features of the new draft are set out beginning on page 4 of your briefing note. The draft is presented, as you've heard, in the college's new format for standards. You'll note some sections that reflect our modernization efforts. So for example, the use of an executive summary and principles. The draft retains many of the key topics covered in the current practice advisory, like the elements of consent and requirements related to substitute decision makers, but much of the content has been revised and updated. Importantly, the draft standard includes some new guidance, which is highlighted on page 5 of your briefing note. It includes new requirements related to refusal or withdrawal of consent, new requirements related to use of staff to help obtain informed consent, expectations related to the use of consent forms, and new guidance for emergency treatment. The draft standard also omits some content from the current practice advisory that was not seen to be clear or accurate, or which we felt might be better suited to an FAQ document. On the last point for emphasis, the final standard, like most of our other revised standards, will be accompanied by an FAQ and other supplementary resources to help explain and expand and clarify the requirements of the standard. Those resources haven't been drafted yet. They're not part of this consultation or the package of materials that were brought forward to council. What we wind up developing will be informed to some degree by the feedback we receive following the consultation, but you will see those supplementary resources when the standard comes back for final approval sometime next year. And so the decision before you, firstly, if you have questions or feedback concerning the draft standard, I'm happy to respond to them. And the decision ultimately is whether you approve that the draft standard be released for external consultation.
Thank you, Cameron. And I am seeing no hands. So at this point, Nancy.
Thank you, Hanno. Thank you, Cameron. I approve the document as is, but I just had a couple of comments, and I don't know if this can be a consideration for the FAQs. The provision number 3 on page 163 of the package notes, where it deals with the registrant must ensure that individuals have the knowledge, skill, and judgment if they are obtaining consent relying on staff. I thought perhaps maybe we should be specific as to how the registrant must ensure that individual has the knowledge, skill, and judgment. For example, do they need to be a level 2 assistant? Should they be a hygienist or a certified dental receptionist? should they have a minimum of dental experience of 2 years? I think it's important to be clear as to what we mean by they must ensure. So that's my first comment. And then the second comment is in regards to provision number 23 on page 167. And that refers to, sorry, I'm just scrolling to that area. Whereby a minor that we've determined is capable to consenting to treatment. However, they are not able to enter into a financial legally binding contract. Should we be giving registrants, I guess, some guidance? What do you do in that situation? For example, if you have a 16-year-old patient who needs a root canal treatment, for example, and they consent to the treatment, but the parent who is paying for the treatment says no. What does a registrant do in that situation? So again, I'm not sure if that falls under frequently asked questions, if it's something that we considered, but it's just something I thought of when reviewing the package materials.
Yeah, thanks so much,
Thank
Nancy.
you.
Thank you. Yeah, I think those are both really excellent points. Sort of on the face of them, they both sound like good candidates potentially for an FAQ. But if you're comfortable with the draft in its current form going out for consultation, then we'll just take this sort of aside effectively and sort of work these two issues up and think about where best to situate them when we revise the draft after the consultation.
Thank you.
Thank you. Seeing no other speakers, could we have motion number 2 on the screen, please? Oh, excuse me, Anthony Lisho, did you have a comment? Okay. Motion number 2, that council approves the release of the draft standard of practice, consent to treatment as set out in Appendix A of the resources for external consultation. That's moved by Nancy, seconded by Brian Smith. All those in favor, please raise your virtual hand. And that is carried unanimously. Thank you very much. You may lower your virtual hand now. And moving on, we will continue on the subject of standards of practice. This item concerns important updates to the college's professional guidance on boundary violations and sexual abuse. The materials for this item are at pages 171 to 189 of your meeting package. And just a reminder, when it does come time to ask questions, council, in this public forum, please do not raise any specific cases that you are aware of. This is about the modernization of the policy in general. And this will be an item for council's decision. And we have Shivani Sharma, Senior Policy Analyst, to lead us through this material. And Shivani, at this point in time, I'm going to turn it over to you, please.
Thank you very much. I'm just going to get my slideshow up for you. All right. Can everybody see that or no? Let's see. Okay, good morning, everyone. I'm here to talk to you today about the draft standard before you for consideration for approval for external consultation, and that is on the prevention of boundary violations and sexual abuse. We're just adjusting the screen because I see that it's still a little hard to see. Okay. So the purpose of this brief presentation, I'm seeing the screen is still a little stuck, but that's okay. I should be able to continue to speak about it if IT cannot support. Let's see. All right. So I'm going to just be providing you with a very brief presentation, just looking at the background of the standard, how we developed it. I'll also walk you through some of the newer requirements that are part of the standard that did not exist previously in the current practice advisory that we have. And I'll also be talking to you about the associated case scenarios, and then we'll leave the floor open for any feedback and questions that you may have. So by way of reminder, the policy team, as you heard this morning, was tasked with going through a standards prioritization process. And as part of that, we reviewed all of our RCDSO resources and we ranked them in terms of priority for review and for updating. This is the practice advisory that is currently in place that speaks to preventing boundary violations and sexual abuse. It was developed in November 2017. And when we reviewed this particular document, we ranked it as being high priority, mostly because there were aspects of it that needed to be updated to be able to reflect current legislative requirements. There were also aspects of this that weren't as comprehensive as we would have liked them to be. And we wanted to provide more examples in general of boundary violations and the less obvious cases of sexual abuse. So we went ahead in presenting our analysis of this to the Quality Assurance Committee, and the Quality Assurance Committee directed that a new standard be drafted. This is similar to the slide that Cam presented earlier this morning. However, it is in relation to the specific standard. So we did not go through a preliminary consultation on the existing practice advisory, which would have normally been a step. And the reason was because we were already well aware of the shortcomings of the current practice advisory. And we also wanted to just expedite the creation of the new standard. It is pertaining to serious subject matter. So we went ahead and we conducted research. We drafted the first draft of it, and we worked with the Standing Policy Working Group in July, and we worked specifically with them on the creation of the dual relationship requirements. And then we worked with the Patient Relations Committee. They actually saw the very first draft of the standard, and we had some targeted discussions with them regarding the dual relationship requirements relating to gift giving and receiving, also trauma and violence informed care. We integrated the feedback that we received from both the Standing Policy Working Group as well as the Patient Relations Committee into the draft that we had, and that was presented to the Quality Assurance Committee, who provided minor feedback. We integrated that, and that is in the draft that is before you today. So that's where we are right now, is the purple circle right in the middle of the screen. And we're just looking to hear about your feedback on this current draft, as well as whether you approve for it to move forward for the public consultation. I'm just going to talk briefly about the way we developed this particular standard in terms of the research that was conducted. So we conducted an environmental scan looking at all relevant content from Ontario regulatory health colleges. And we looked at their primary resource content. So this was their main content pertaining to boundary violations and sexual abuse. And then we ranked the content in terms of themes. And that is in part what informed sort of the topics that are addressed in this particular draft that is before you today. We also looked at the content that was created by other Canadian dental regulators, and that also helped to inform our analysis.
Then we wanted to look specifically at the RCDSO context. So we talked to our practice advisory service, and they were able to tell us about certain inquiries that registrants have been making about boundary violations and sexual abuse. We also spoke to our professional conduct and regulatory affairs department, and they shared with us some of the cases that were seen at ICRC as well as discipline. And we also reviewed some of those cases and decisions. Then we conducted a very targeted literature review, specifically in relation to gift giving and receiving, dual relationships, and trauma and violence informed care. And that was part of the research that was presented to the Staying Policy Working Group as well as the Patient Relations Committee. Ultimately, the standard addresses all of the topics that are shown on this slide. The ones that are in bold, that is items 3 to 6, are the newer aspects of guidance. And what I mean by that is that RCDSO has not produced any written resources that explain these areas previously. So this is the first time that we will be addressing them. So when we're looking at item number 3, that's on appropriately managing gift giving and receiving, it's provisions number 7 to 9 in the draft standard, and that's on page 182 of your council materials. We're not prohibiting gift giving and receiving, but we have asked for registrants to consider some things and keep their professional obligations in mind in order to ensure that patients' best interests are kept in mind and that patient care is not compromised. We also have new requirements relating to appropriately managing dual relationships with patients. That's provisions number 10 to 12, and you can find that on page 183 of your materials. Dual relationships just means that a dentist is providing care to someone that they have a pre-existing relationship with, for example, to a friend or to a family member. So these are relationships outside of the spousal exemption, of course. And this is also an area that we had previously not had any written guidance on. And so we developed a specific list of considerations in provision number 11 of the standard to assist registrants in understanding what their professional obligations would be if they were to be in a dual relationship. We also have new requirements relating to appropriately managing relations with persons closely associated with patients, again, just to ensure that the patient's best interests are kept in mind and to ensure that patient care is not compromised. And we have some new requirements relating to providing trauma and violence informed care. That is provision number 15 in the standard, and it's specifically at line 216. I do want to take some time to highlight that specifically because this is a very I would say, a new area in the sense of it being increasingly being recognized by health regulatory colleges in Ontario and by health professionals in delivering care to patients. So while this topic has been addressed by some dental educational institutions, as well as in the realm of continuing educational programs, now regulators are starting to think about requirements in relation to this and providing resources to assist their registrants in learning about this and being able to deliver appropriate care. The reason for incorporating this into this particular standard and what is really important to note in the context of dentistry is that there are some groups of people who have experienced trauma or violence and as part of that have experienced trauma that is specific to the oral area or the oral facial area. And so we thought it would be very important for dentists to understand how to interact with these people. If you saw in the briefing note, we had provided you with some statistics demonstrating that about 63% of Canadians have experienced trauma at some point in their lives. And there have been around 11 million Canadians as of 2018 that were reported to have been experienced some form of physical or sexual assault. So the chance of a dentist coming into contact with a patient that has had some form of trauma or has been a victim of violence is high. And we wanted to make sure that there would be requirements that could assist dentists in understanding how to interact with this particular group of people. The reason it also is in the standard is because experiencing violence or having trauma will have a direct impact on a patient's sense of boundaries. And it also has implications for access to care because if a patient doesn't feel safe and doesn't feel as comfortable as possible during their dental care experience, they won't want to seek oral healthcare. So this is why we are addressing it over here. But I do also want to emphasize that the RCDSO is not an expert on this topic. And as part of the consultation, we will be consulting with experts to ensure that the requirements that are in the standard are sufficient and accord with best practices. We also have case scenarios that are part of your council materials. You can find these on page 187. And these were really developed after speaking with the Professional Conduct and Regulatory Affairs Department. We wanted to understand where some gaps were occurring in terms of registrants maybe not understanding their professional obligations in certain areas. And that is how we decided to address the particular range of topics, number 1 to 4 on the screen. The idea really is to help registrants understand their professional, legal, and ethical obligations. It almost gives life to the requirements in the standards so that registrants can see how it may look like in dental practice. I do want to emphasize that this isn't going to be all of the case scenarios. We are planning on developing more. We are hoping to develop one on dual relationships. We are also hoping to develop one on gift giving and receiving. The reason why we haven't developed it already is because we wanted to first consult on the requirements before moving forward to creating those case scenarios. And we will also have an associated FAQ that will further sort of move into explaining some of the requirements in the standard and providing further guidance for registrants. These case scenarios today are not for your approval, but we will welcome any feedback that you may have about them. So we move forward now to the questions for you. We're looking for any feedback that you have to provide or any questions that you have about the presentation or about the standard. And then we can move for the motion after that.
Thank you, Shivani. I see Daniel's hand is up, and again, just a reminder, council, that questions and comments are great, but no specifics. This is sort of policy in general. Daniel, you're up first.
Thank you. First of all, I think the document is extremely well done. I'm very supportive of the document. I have a very trivial point to raise, and it has to do with the definition of patient, which is on page 179 of our notes, and I guess the second page of the standard. And I guess as a dentist, I don't think of a patient the way this is being listed. There are 4 points that commonly would apply to a patient, but I think it's too much detail that potentially could be problematic. And if I take just a very extreme example, if I don't charge a patient, if I'm doing pro bono work and I don't write anything in the health record, that person's not a patient based on this. And therefore, you can't apply the standard against me in that case. So I know the footnote states that the definition of patient specific to the sexual abuse and spousal exemption provisions in the RHPA. And I may have missed it, but I looked up the RHPA, and at least the version that's posted as of Wednesday in the section on sexual abuse and spousal exceptions has a different definition of patient. It's much more simple. It's more intuitive. And I'm wondering if we actually need to define a patient, if we could just go and use it's on page 26 of the RHPA. If we could use that instead, and just something for you to consider, because I don't find this definition helpful.
This was taken from the legislation unless there was a recent amendment that I am unaware of. So we can look into that and see if there was a change recently and incorporate that if there was one. But this was taken from the legislation, at least at the time that we were drafting the standard.
That would be great. Again, the current version of the RHPA, it's on page 26, defines it, and then it refers to clause 43(1), which I couldn't find this definition, and perhaps I just couldn't find it. But in doing word searches throughout the RHPA and the different clauses, I couldn't find this definition. And they have a very simplified definition currently, which if you need to define it, might be more, I think simple might be better than more complex in this case.
Okay.
But if you can look into it, that would be great. Thank you.
Sure. I will double check that. This was the definition that was provided under the regulation patient criteria under subsection 1.6 of the Health Professions Procedural Code. So I will double check to see if there have been any recent amendments.
Great. Thank you. Appreciate it.
Dan?
Yeah, sorry, I think you're both right. There is a definition under the RHPA. Shivani's referring to an actual regulation that exists under the RHPA that goes into this level of detail for defining a patient. So it is a law, and Alan may be able to provide more commentary to that. But This is within a regulation that exists. And it's actually footnoted in that, on that particular page.
Right, but the footnote refers to the RHPA, which is why I went into the RHPA.
It refers to Ontario Regulation 260/18. We will look into it, but that is a specific regulation.
Yeah, sorry, because I just saw footnote 3, which refers to the RHPA. So footnote 4 was the prescription of a drug. So I thought that was a distinct reference, because footnote 3 talks about a patient is an individual receiving care from the dentist if any of the following circumstances exist. So that's the footnote referring to the RHPA where I couldn't find it.
Yeah, we'll provide some clarity to the footnotes just to make sure that it's clear that section, the footnote number 4 applies to that.
Thank you. Nancy?
Thank you, Hanno, and thank you, Shivani. Great work. I do support the draft. I just had one recommendation perhaps to consider, and it's in regards to expanding the definition of spouse under point number 85. Perhaps we should consider pointing out the criteria for who qualifies as a spouse, a common law partner, or an adult interdependent partner, by stating, you must be in a conjugal relationship and you share one another's lives and you are emotionally committed to one another and you function as an economic and domestic unit. There are many different living arrangements for different partner relationships, and I think we need to be very specific as to what criteria we consider in this provision.
Thank you. I
you.
know that you're referring to, I believe it's case law that speaks about common law relationships and the factors that are commonly considered by courts in determining whether that exists. That could be something that's either could be incorporated into a footnote or also part of an associated resource. So would you be comfortable with us taking that back and determining where to best place that?
Indeed. Thank you.
Thank you. Ellie?
Thank you. On page 185, number 22. It states that dentists must not become involved in a sexual relationship with a patient for at least 1 year after the termination of the dentist-patient relationship. My question is, must there be an express statement regarding the end of the dentist-patient relationship? Or is it sufficient that the patient hasn't attended the dental office for 1 year? I know in one of your scenarios, a patient didn't return to the office for 6 months, but that was not sufficient because it's possible that that person is still a patient, given the fact that 6 months recalls are sort of the standard or the norm. But if there is must there be an express statement regarding the end of the dentist-patient relationship, just to clarify?
Given that it's common for there to be gaps in dentistry care, we felt that there would have to be an express termination or ending of the relationship in order for that provision to apply. So that's part of, as you had recognized, the case scenario to illustrate that. But it's also derived right from legislation, that 1 year requirement. So we were just making sure that we were consistent with that requirement.
But how do we know when it's the end of the relationship? Should that not be in the guidance or the standards? Should that not be put in there that until you expressly state this is the end of the relationship, the time doesn't start running for the 1 year?
That's another thing that we can consider as part of the FAQ, I think, providing some more information on that. are you comfortable with us taking that back and considering how to further clarify that?
Yes, of course. That's great. Thank you.
Thank you, Alan.
I just want to add that a relationship between patient and dentist doesn't end on the passage of any particular point in time. I don't need to see my dentist for 5 years, and that person might still be my dentist. So it's a combination of factors that determines whether or not there's still a dentist-patient relationship. What the RHPA does is talks about how long you're a patient for in the concept of sexual abuse, and that saying after 6 months, okay, we're no longer a patient, and dentists, you agree, and the person, sure, right? Doesn't make them no longer your patient for RHPA sexual abuse terminology, but it's complicated because in outside of that, it's not a time period. It's not, I haven't seen my dentist in a year or two, so that person's not my dentist anymore. So it's all factors that go to determining whether that relationship still exists.
Thank you. And thank you again, Shivani. I have no one else on my speakers list. So if I could have motion number 3 on the screen, please, for council's consideration. Motion 3, that council approves the release of the draft standard of practice, prevention of boundary violations and sexual abuse as set out in Appendix A for external consultation. That's moved by Vivian, seconded by Mark Trudell. All those in favor, please raise your virtual hand. That is carried. Thank you very much. Next on the agenda is a presentation from Council Member Dr. Noah Goma of Western University. Dr. Goma was a presenter at the inaugural Canadian Oral Health Summit 2024, which took place in Halifax this June. RCDSO Registrar and Deputy Registrar were also in attendance. The materials for this item are on pages 190 to 191 of your meeting package. And I will ask Dr. Goma to provide her thoughts and reflections from the summit. And no, I'm going to turn it over to you now, please.
Thank you, Hanno. I'm going to share my slides. Can you see that okay? Just give me a second. All right. Hello, everyone. It's a pleasure to be talking to you today about the Canadian Oral Health Summit and give you a collective high-level overview of some of the work that has been driving oral health and oral health care policy recently. So before I begin, I would like to just state some potential conflicts of interest. So I'm just going to read them out to you. Due to my roles as an academic, researcher, and educator at the Schulich School of Medicine and Dentistry at Western University, I have participated in the consultations for the development of the National Oral Health Research Strategy, on which I have co-led the Knowledge Mobilization Implementation Science Strategic Priority. I sit on committees and working groups at the Association of Canadian Faculties of Dentistry, Canadian Association of Dental Research, and the Network for Canadian Oral Health Research, who have all contributed to planning of the Canadian Oral Health Summit. My research at Western University is funded by the Canadian Institutes of Health Research, which was also a key contributor to COHS and NORSE. So last June, the long-anticipated Canadian Oral Health Summit took place, a first-of-its-kind event in which several academic, professional, and research leaders, including deans, academics from different levels, leaders of professional organizations, including the CDA, the CDHA, CDTA, as well as representatives from provincial regulators, including the RCDSO, and leaders from in the Canadian Dental Care Program, the Federal Minister of Health. So everyone came together to present and discuss developments in oral health and oral health care in Canada and internationally. So I'm gonna, in the next coming slides, give you an overview of the discussions at COHS. So specifically, what am I hoping to communicate to you today? We're gonna answer 4 questions. What are some of the national, international initiatives that are shaping oral health and oral health care policy? How have these initiatives helped inform Canada's strategic priorities for oral health research? What are some of the necessary tools for advancing Canadian oral health research, and what might a regulator do to advance oral health care through research? So of relevance to Council is that several discussions at COHS centered around issues of access to oral health care, dental workforce planning, dental education, which all dovetail very well, of course, with the college's mandate to serve and protect the public interest. And it informs the college's strategic plan, particularly the professionalism pillar and strategic priority of access to care. So what are some of the national, international initiatives that are shaping oral health and oral health care policy? So one of the most significant global oral health initiatives, and I would argue the most significant one, was the release of the Global Oral Health Status Report by the World Health Organization in 2022. And the report reviewed the most recent data on major oral diseases, risk factors, health system challenges, and opportunities for reform. And it provided, for the first time, oral health profiles by country for each of the 194 WHO member states. The report's conclusion was that the status of global oral health requires urgent action. The report also aimed to serve as a reference for policymakers and an orientation for a wide range of stakeholders across different sectors to guide advocacy towards prioritization of oral health. Coinciding with the Global Oral Health Report, or as a result of it, was the release of the Global Oral Health Strategy and the Global Oral Health Action Plan. And these outlined 11 targets that are to be accomplished by 2030, with responsibilities spread across the WHO member states and other WHO partners. So what are the 11 targets? So you will see here that the front and center to these targets is universal healthcare coverage for oral health, such that by 2030, 80% of the global population are entitled to essential oral healthcare services. There are also targets related to oral health governance and legislations that, for example, phase out amalgam, as stipulated in the Minamata Convention on Mercury, which was ratified by Canada in 2017. And other targets concern the implementation of policies aiming to reduce sugars, for example, having a health workforce policy that responds to population oral health needs, the inclusion of dental care, particularly dental preparations as essential medicines. And then we have information or oral health information systems or data systems that can monitor oral health policies. And finally, each of the member states should have a national oral health strategy or an oral health agenda that can guide pressing research questions and inform oral health policy development. So circling back to Canada, let's see how these 11 global targets have corresponding national initiatives. So for an example, corresponding to the universal healthcare coverage for oral health, we see that the Canadian Dental Care Plan was released to alleviate cost barriers to dental care for Canadians based on, of course, decades of studies showing oral health inequalities in Canada. And we also see that actions to phase down dental amalgam, such as promoting the use of best environmental practices in dental facilities, to reduce the release of mercury, and restricting the use of dental amalgam to its encapsulated form, and so on and so forth, are examples of how there are corresponding initiatives in Canada to the WHO global targets. When it comes to dental workforce planning, a lot of this is also being discussed, and we just heard in Dan's report, there is additional pathways for licensures are being discussed to accommodate something and other workforce planning to accommodate the CDCP and so on. On the data side, the need for global target for having information, oral health information systems. Statistics Canada is launching the Oral Health Statistics Program, which I will revisit in a few slides. So a lot is happening, as you can see, on the oral health front, globally and locally. And there was need to streamline questions into a strategy or an agenda that can direct oral health research over the coming years, all of which has led to the development of the National Oral Health Research Strategy that was released at COHS in June. So the National Oral Health Strategy, or NORS, was a collaboration between several entities, from research institutes to professional academic associations. And you may recognize the two people in the photo, Dr. Paul Allison, professor and former dean of the then Faculty of Dentistry at McGill University, and Dr. Leah Rock, director of the School of Dental Hygiene at Dalhousie University, and who were both the co-chairs of NORS and were behind the orchestration of bringing people together and organizations to create this inaugural document. And as you can see from the timeline here, it started by the initiation of in 2022 and an open call to participate up until the final launch in 2024. Several entities were consulted along the way, including the general scientific community, the oral health community, as well as patients and the public. So it was an inclusive document that captured diverse perspectives. And the aim of NORS, as I mentioned, is to inform several stakeholders, including governments and decision makers, funding agencies, researchers, and organizations on emerging priority issues for Canadian society. And innovative methodological, technological approaches to address these issues. So let's take a deeper dive into NORS and see how oral health and oral healthcare research in Canada will be directed over the coming few years. So NORS has identified 6 strategic priorities that can be summarized as 2 leading issues, including access to care and inequities and identities, 2 overarching approaches that include knowledge mobilization, implementation science, and I'll get into the details of that later, and environmentally sustainable oral health care interventions. And finally, 2 emerging methods that include artificial intelligence, which we have spoken about this morning as well, and omics, or in other words, collectively, genomics, epigenomics, the microbiome, transcriptomics, and other high throughput methods to study oral health. So for the sake of time, I'm not going to go through all of these in detail, but I will highlight some of them and some of the research questions that have been identified by NORS as possible directions for research questions that can stem from the strategic priorities. So let's take access to oral health care for an example. NORS is directing researchers and stakeholders to work together to assess the impact of dental care policies and programs, such as the CDCP, of course. Is it working? What is the reach looking like? Is it doing what it was supposed to be doing in terms of alleviating cost barriers to dental care? Is it reducing inequalities, closing the social gap in oral health? And then comes the question of workforce planning. How do we develop and evaluate training programs for oral health providers that can equip them with the knowledge and tools that are necessary to provide professional and quality care? Another strategic priority on NORS, and one that I think we think about all the time due to its rapidly rising role in our lives and in our future, is artificial intelligence. And it's great that the college is developing documents at the moment on artificial intelligence. So oral healthcare can definitely tremendously benefit from AI applications in several capacities, starting with developing AI-based tools that can leverage the wealth of multimodal data that is available at the clinical or hospital level, so as to improve or even sometimes predict patient outcomes, as well as applications related to things like virtual care, teledentistry, for example. And importantly, there needs to be a direction for research in this area that investigates the possible use of AI that establishes ethical and secure management practices in light of HIPAA and so on. So Norse also focused on environmental sustainability, where we need to be meeting the needs of the present without compromising the ability of future generations to meet their own needs. So briefly, this directs collaborations in this area to focus on developing, implementing, and then evaluating sustainable interventions and technologies at several levels: micro level, meaning in dental materials, equipment, processes, and then meso level, such as operational interventions at the dental clinic level. And then eventually at the macro level, where we need to reform oral healthcare systems and possibly governance in a way that meets environmental sustainability needs. And all three levels, I think, are relevant to the college's work in providing guidance documents and working with legislation, policy, and guidelines to drive sustainability in oral healthcare. Okay, so of relevance to the college's mandate and work, as well as the strategic priority on knowledge mobilization implementation science. So what does that mean? Implementation science is essentially the study of uptaking why evidence-based or evidence-informed policies and interventions are actually incorporating them into practice. So we know that on average, there is a gap between evidence to practice, which we also call the no-do gap, that is estimated to take an average of 17 years. And the incorporation of research evidence into clinical practice is, I think it's a lot of years to considering that 20 years is considered an intergenerational gap. So this strategic priority is concerned with researching the best barriers and facilitators to the implementation of evidence-informed oral healthcare interventions, as well as devising methods and tools to facilitate scaling up and use of these interventions and build capacity in this area. So it is important that knowledge users, policymakers, and regulators are engaged and are at the implementation science research table, because it is in the best interest of the public that what we know works is actually implemented and used in a timely fashion in order to maximize its benefits. So in a nutshell, what the National Oral Health Strategy was about, I've just covered. And there were also discussions that centered around how do we implement these strategic priorities? What are the necessary tools that we need to actually execute these research questions? The first thing that comes to mind is data, of course, because we cannot evaluate what we cannot measure. So how can we, for example, evaluate the performance of, I will always go back to the CDCP without having the data to tell us about it, right? And so this is where collaborations with Statistics Canada come into place. So StatsCan are working on the oral health statistics program that comprises national survey data. And you may have already heard of things like the CHMS or the COHS. Or you may have been also asked to be a participant on the survey of oral healthcare providers. So the program also provides data on administrative data, such as CDCP claims data, membership data, and so on. And this is really a timely program because a lot of the literature and the evidence on several oral healthcare interventions at the population level come from the US or other parts of the world, simply because traditionally we have not had the robust kind of population data to support some of the research questions that we always wanted to ask. So I think this is a really timely program. So you may be familiar with the Canadian Oral Health survey, or the which specifically asks questions about oral health and cost barriers to oral health care. And then there's the survey of oral health care providers. which focuses on the financial aspects and operational characteristics of oral health care providers in Canada. And these results are expected to help assess the current state of the oral health care system in the country, while providing insight into the changes that can impact this sector, including the implementation of the CDCP. At COHS, there was also a lot of focus on patient and public engagement in oral healthcare research. And there is definitely a welcomed emphasis on engaging people with lived experience, carers, and members of the public as research participants, or as research partners, actually, to understand what research questions matter to them. And this is to eventually improve patient-oriented oral health research and work towards ensuring that clinical interventions are informed by patient preferences and experiences. So circling back to the mandate of the regulator, which is to serve and protect the public interest, what might a regulator do to enhance the oral health of the population through research? So the college is already doing a lot in this area. A regulator can support data-driven oral healthcare in its guidances. A regulator can also enable research tool through supporting data collection, sharing, and linkage, and be involved and present at the table and discussions around emerging methods such as AI in oral healthcare and its potential, and also its implications to health information. And last but not least, engage in discussions around the implementation of evidence-informed interventions. Making use of and implementing the best evidence that is informed by patient preferences and experiences is key to the provision of quality care and access to care, both which are virtues of professionalism and are integral to our social contract. So, key takeaways. To me, arguably, I would say that never has it ever been such an exciting time to be an oral health academic and researcher as it is right now. Oral health is under the spotlight on several global and local fronts, and discussions are happening at various levels. And this makes it all an excellent opportunity to advance population oral health through collaborations between the various stakeholders, including oral health professionals, academics, and regulators. And so it doesn't matter what hat we wear, whether you're a dentist in the community or a council member or a patient or an academic, we all have a role to play in the oral health research agenda. And that is all from me. So thank you very much for your attention.
Thank you very much, Noah. Council, any questions? Okay, seeing none. Oh. Okay, thank you. Erin.
Thank you for the presentation. It's wonderful to see all the initiatives that are in place, particularly now in the times that we're living through. My question is about the metrics and KPIs that we're using to directly measure oral health, which is our ultimate goal. It seems now we have a lot of ways to measure utilization and uptake. And the assumption is that increased utilization will lead to better oral health. But do we have any strategies to actually test that? So a collection of data on maybe DMFT, which is decayed, missing, filled teeth. And also, do we have any benchmarks to compare how the interventions that we're putting in place now are actually improving oral health for our population?
Right, excellent question. Thank you, Erin. So yes, most of the data that we have in Canada has been cross-sectional and self-reported, meaning can you rate your oral health on a scale of 1 to 5, or how many times have you visited the dentist over the past year? But recently, we did have the Canadian Health Measures Survey. This is a survey that happens every year, and starting from 2007, oral health was included in cycle 1, and then not again until recently in 2022, when the which is cycle 7, I would say. This is where we have clinical oral health data being collected at mobile examination centers all over the country. So we've got data on DMFT, or like clinical oral health measures, clinical attachment loss, and so on, bleeding indices. So clinical data that is available in the CHMS, and again, it's cross-sectional, so it's not like you're following up the same people over time, but it does give you a snapshot of how things have changed from 2007, 2009, when cycle 1 started, up until 2022 to 2024 for cycle 7. So CHMS is a very promising thing, and we look at our neighbors down the border, and Haines, for example. They have surveys that happen every year that collect clinical data, and hopefully we can eventually include oral health in CHMS every cycle and not have to wait 15 years between cycles to get clinical oral health data. So thank you.
Thank you, and thank you again, Noah, for that comprehensive report and for taking the time to do a report for council. It's very much appreciated. We have one item prior to lunch, and that is regarding the RCDSO Strategic Plan 2023 to 2025. This report is a regular feature of council meetings. It gives council a comprehensive overview of ongoing projects. The materials for this item are on pages 192 to 215 of your meeting package, and this is for information. And at this point in time, I'm going to ask Deputy Registrar Andrea Foti to walk council through the general update. Andrea.
Yes, thank you, Hanno. I'll keep my remarks brief. I'm going to direct your attention to starting at page 194 of your package. As Hanno said, this is our standard report that we provide to you every council meeting. And the goal specifically, and the reason I've directed you to page 194, this is where we have in these charts a snapshot for you of what's happened since your last council meeting with each project. Okay. I'm going to go through them very briefly because the first project, as you can see, is college standards. You've heard from Cameron this morning. You have a good handle on how that project is proceeding. Access to care, you can see some content here. And later this afternoon, you're going to hear from our project lead, Michelle Cabrera-Gali, who is going to take you through some of these points and expand. So I don't want to steal her thunder. I'll let you read that at your leisure, and then Michelle will take you through that project. What I may do is just pause on the next project, Service Experience. This is led by Michelle Tremblay. You see here a few things. Dan's touched on some of them. Most notably, the change that we'd highlight for this meeting is the changes to the members portal. Dan gave you a snapshot of that. And really, this is, I think, something to flag is this work has been based off of feedback we've received from dentists. So it's really an effort to try to be responsive to the issues that they've expressed to us, how they like to use that portal, and go forward from there. EDI, you're going to have the benefit of hearing from Michelle Tremblay and Nizar Ladakh later about an EDI statement, but you can see here in the project update, lots of activity. This is a very active strategic project, and it really spans a few different aspects, as you can see from the update, focusing on training for staff, for council, ways that we can use our existing products, projects and processes to try to advance EDI. And highlighted here is something Dan touched on this morning, the recent partnership with Rainbow Health Ontario, which is really an incredible organization. Lots of resources that we want to have Ontario dentists be able to access. And I would say the last thing I'll focus on is this project is also focusing on language and how can we best respond to and serve individuals in languages that are most comfortable to them, that they're comfortable speaking. And you can see here, we've published now complaints information in 11 different languages. And those are selected in consultation with our translation service, MCIS Language Services. governance review and modernization. I know that our project manager, Laura, has brought to you today a few items that you'll go through this afternoon, and you can see some of those outlined here. I think you can also see the cross collaboration between some projects as well, with some items highlighted here, such as the training on bias that have also been captured in our EDI. So that's just an indication of how we're working together across some of these projects. Last but certainly not least, we have our practice models in corporate dentistry. You have a briefing note from Denny Ogarindi, our project manager, in your materials today. Again, a really active project. Denny, we are hoping we're going to have Denny come back to your October meeting and provide a more extensive presentation for you, because she's doing a lot of really great and important work. So I'll leave it there. You also have attached, as always, as an appendix, Appendix B, you have our council dashboard. And so that's just to give you a page number, that's starting at page 202, where you can see some of the metrics and how we're advancing on those. But I'll leave it there, and if there are questions, I'm happy to help.
Thank you for the update, Andrea. Any questions from council? I'm seeing none. So at this point in time, we will break for lunch, and I would ask you to be back at your computers for 12:55, please, so that we can begin with our afternoon session. And just a reminder, it would be helpful, council, if you could turn your video off, and we will see you back here in an hour. Thank you. Back, council. The next item on our agenda represents an important development in both the strategic plan and how the RCDSO has evolved its equity, diversity, and inclusion competence. The materials for this item are on pages 216 to 223 of your meeting package, and this matter is for your information. Presenting this work to us is Michelle Tremblay, Organizational Transformation and College Equity Officer. So at this point in time, Michelle, I'm going to turn it over to you, please. Okay, Michelle, I think you may be on mute.
Oh, sorry about that. Can you see my screen okay?
We can see your screen, yes, and now we can hear you.
Fantastic. Thank you, Hanno. So good afternoon, council, staff, and those joining us on the live stream today. I'm here to bring you a report about the RCDSO's efforts on equity, diversity, and inclusion. And the reference for our discussion today can be found in your council materials on page 216 to 223. I was looking forward to being with you in the room today, but as children return to school, they often bring gifts like colds and flus home to their parents. So I am home, and I'm happy to respond to any questions you might have after my presentation, and my email is also in the package. I don't sit here today with everything figured out. And to be honest, this work has been difficult and it's always evolving. Before we dive in today, I want you to take a moment to think about when you first began to think about issues related to equity, diversity, and inclusion. And when you first felt confronted with topics like power, privilege, social location, systemic racism, barriers, and belonging. Perhaps your experience began when you immigrated to Canada and had to navigate a new land, a new language, or culture. Or maybe you experienced barriers in your career at a time where there were few women in leadership and your voice was dimmed. Or perhaps your journey of thinking about these issues began in more recent days, like after the death of George Floyd. Or perhaps when our country had to look in the mirror and face the horror of residential schools and the generational impact on Indigenous communities in Canada. Or maybe you have yet to truly call in these conversations and a voice is coming up inside you saying, why is this any of this relevant for a regulator? So I'd like to ask you today, as we move through this update, who is the public that you serve? Who is the public that you serve? I'd like to offer that the public that you serve are persons with disabilities, like the Canadian Society for Disabilities and Oral Health described to us at December's council. Many who struggle to find a dentist who will take them on as a patient. I'd like to offer that the public that you serve are members of the 2S LGBTQ+ community who seek culturally competent care. I'd like to offer that the public that you serve are members of Indigenous communities where trust in the health system and health providers has been broken and access to health care has been challenged, who lag behind all other Canadians on most key health indicators. When we say that we're working in the public interest, each of us has value. And so it's our responsibility to do something in our mandate within EDI. And it's our responsibility as a regulator to look at our workplace, our policies, our decision-making, governance, and learning, and make it part of our business to ensure that standards of practice, processes, and services are inclusive. As Dan mentioned in his registrar's report earlier today, just this week, we saw an authentic and powerful apology from the CMA. They formally apologized for their role and the role of the medical profession in the harms caused to Indigenous peoples in the health system, both through action and inaction. It was an emotional and healing event, and also a multi-year journey that the CMA took in partnership with Indigenous communities. And they explored the devastating impacts the health system has had on Indigenous people. To date, this apology has been viewed over 8,000 times, literally in the past 24 hours. And so I'd encourage council to watch this healing ceremony. It's about 2 hours, and the apology on YouTube. So let's talk about our work in the RCDSO's journey. And this work is about taking steps similar to what we saw with the CMA this week. You might recall that our journey began from the inside, looking at our workplace. In 2021, the college worked with the Canadian Centre for Diversity and Inclusion to prepare a current state inclusivity assessment. And this report was to form our baseline data. And the intent was to create a data-driven strategy to inform our future decisions on EDI in our workplace. We had about 84.7% of our staff take part in our diversity census and inclusion survey. And the report analysis through comments from the survey directed the college to look at our policies, our hiring and advancement strategy, our flexible work and accommodation procedures, and set up EDI accountability within our leadership. The report also provided us some baseline demographic data about our staff, and we continue to monitor inclusivity, diversity, and belonging at the college in a number of ways, including a staff survey that we deliver every 2 years. And in fact, this staff survey is coming up in October of this year. And it will help us review again the sentiment of inclusivity, belonging, and the sentiment that staff have on our work to date on EDI. In another response to this report, the college put a call out to staff, and we formed our first Inclusion, Diversity, Equity, and Accessibility Committee. And this is comprised of 7 volunteers from various roles and levels and diverse backgrounds throughout the college. The group has a goal within our strategic plan to review all of our internal policies by the end of 2025. And you'll see that in Andrea's report, a dashboard that includes our progress to date on reviewing those internal policies. The IDEA committee also plays a significant role as staff ambassadors on EDI. They meet monthly and offer valuable perspectives to me and to the college on challenges and opportunities that we have for our colleagues, the college, and the public. And I'd like to publicly thank the IDEA committee for their commitment to EDI at the college. They're listed here, but it's Alana McCutcheon, Danielle Rodet, who's in the room with you today, Daphne Pereira, Grace Kim, Mark Edelstein, Michelle Cabrera-Gali, who you'll hear from later today, and Dr. Peter Hong. Thank you all for your hard work. In addition to that act, we also developed a flexible work framework. Our organization continues to be a flexible work environment where staff are able to work at our main office at 6 Crescent or remotely. We understand through the research that maintaining a flexible work environment supports attracting and retaining a diverse workforce, folks at different life stages, abilities, and needs. And in the spring of 2024, just this year, we launched our framework that articulates our aspirations for a workplace that thrives in a flexible workforce. And so these principles of EDI are embedded throughout this document and help to anchor our staff in what it means to thrive in a workplace while we're working in a distributed way. So another response to this inclusivity report was my role as College Equity Officer that began in November of 2022. And shortly following this appointment, our EDI strategic project was developed and kicked off in January of 2023. And the scope of this project, and where we'll spend most of our time together today, anchors to 4 objectives. The first is nurturing a culture at the RCDSO where diversity is our strength, establishing and deepening our partnerships with Indigenous communities. The third is building in EDI accountability into our daily operations and our regulatory work. And finally, supporting efforts to improve access to care in Ontario. And I'm going to take you through some of the highlights of this work, and some of it you would have read in your briefing note. To date, between council, staff, and committees, college representatives have participated in over 100 hours of EDI training and enrichment experiences. And many of you have had guest speakers, workshops, presentations, and committee-specific training. And I'd like to thank you for your participation in that work. And we're doing also what we can to put training and resources in front of staff. And in response to a pulse survey last year, staff largely expressed that our efforts around EDI was beneficial to corporate culture. We've implemented mandatory training for all employees on certain topics. And through our employer partnership with CCDI, staff have access to a library of training modules and resources and a diversity calendar that's embedded into our Outlook that allows staff to learn about different cultural dates, observances throughout the year, and be more mindful of inclusion as they're moving through the calendar. I'd be remiss not to thank a very special team member, Nicole Bay. In a few short months since joining the team, Nicole has been instrumental in creating an EDI quarterly spotlight seen here, posted on our intranet for staff. And she spends a tremendous amount of work and effort to curate videos, events, and experiential learning for staff. And she's been an incredible addition to the team. Upcoming, our staff are invited to a Working Black documentary produced by Taboo Community Health Center, and they'll be able to hear unfiltered testimonies of Black Canadian professionals who intimately describe the subtlety and scars of systemic racism in the workplace. Staff will also have an opportunity to take part in a Trans 101 workshop. There will be 2 sessions, and we have some really skilled facilitators from the Get Real movement who offer this session to help us be a more safe and supportive workplace for our colleagues. In many ways, we've covered a lot of ground in our workplace, but there's always work to be done. And so when it comes to the second objective of our strategic project, which is establish and deepen and build relationship with Indigenous communities, we are still on our learning journey. We had elder sought-after speaker Bob Watts, who provided a workshop on the seven sacred teachings at our Leadership Development Day last September. This was a powerful session and really helped us to understand our accountability for decision-making for generations. In November of 2023, the college hosted an RCDSO Connect with Indigenous Services Canada. And this online seminar provided Ontario's dentists with an opportunity to ask their questions about the NAIHB program serving First Nations, Inuit, and Métis patients, and hear directly from program ambassadors about the current state and accurate information about NAIHB services. We continue to build a positive relationship with Indigenous Dental Association of Canada and find ways to collaborate with them and support their efforts in Indigenous oral health care. Dr. Sherry McKinstry and her team are doing incredible work in Saskatoon, and they were also participants at the recent Canadian Oral Health Summit that Dr. Goma described earlier. They'll be hosting their second Indigenous Oral Health Day on October 15th. So please look out for that information online. I'm sure we will post stuff on our channels, and the RCDSO will be participating in that day to celebrate and commemorate with them and their efforts towards improving access to oral health care for Indigenous peoples. As part of our learning journey together, you'll recall that we had a joint learning day with council, staff, and committee members with the College of Dental Hygienists, Denturists, and Dental Technologies in May of last year. And together in this training, we all reflected on the history and culture of First Nations, Métis, and Inuit communities. We covered unconscious bias and the impact on decision-making in healthcare. We learned about traditional teachings and moving forward somehow in our reconciliation journey to improve the health outcomes of Indigenous people. And so we hope to continue to build these relationships, continue to learn, and report back to Council on actions we can take as a regulator towards reconciliation and improved access to care. The third objective here is about building EDI accountability in our operations. And I know both Andrea and Dan mentioned a couple of these pieces, so I'm not going to take too long on this part. But there's a lot of foundational work happening at the college and our teams about how we embed EDI into our operations. As mentioned earlier, we just launched our multilingual guidance on the complaints process in 11 languages, and there will be more to come. You heard our incredible policy team under the leadership of Cameron considering EDI as a critical part of their research, the data they collect, and the sentiments that we see in the materials they're providing to Council and in our standards. And I'd like to spend a few moments on the bolded list related to the HPRO self-assessment, our governance demographic data. And following my time with you, Nazar Ladak will be bringing forward a more comprehensive discussion on our organizational EDI commitment statement. I believe we might have some members of the HPRO EDI network joining us today. This is a network of folks from many colleges who are supporting EDI work at their colleges. As a recap, you'll recall that an anti-racism working group was struck at HPRO, and they worked with a consultant called Greybridge Malcolm to research the relationship between EDI and regulation and anchor actions and initiatives to the CPMF. This working group also developed a number of resources for colleges to use as a reference. And I know Judy Rigby at the College of Dental Technologists was instrumental in leading some of that work. Our team reviewed the guide and took several weeks to come through the guide, and you'll see a sample guide and some menu items in your materials starting at page 231. I also hosted a number of one-to-one meetings with our department leaders, and a survey was created for our department leads to assess the level of action they felt we were taking on particular EDI measures. We also converted the entire guide into a spreadsheet so that our team can go back and reference the menu of items that they can consider as goals and initiatives for their teams on EDI. Connecting EDI big topics into the day-to-day is not always a simple process. As an exercise, each department created a vision statement for their areas. And while not easy, it was an exercise to help leaders and think and connect the dots between these big EDI concepts and their work. I was really impressed by the efforts from each of our teams, and you'll see all of those leaders today in the gallery there. And I thank them for turning their minds to that and encouraging their teams to do that thinking. So with the EDH Pro self-assessment, there were 11 EDI markers rooted in 7 domains in the CPMF listed here. And of the measures listed in the H Pro self-assessment, our team ranked our EDI efforts as 64% proactive. And this is a number that gives baseline for growth. It's not a report card, but a measure in a moment in time. And a more comprehensive definition of these ratings, inactive, reactive, proactive, are inspired by the global diversity, equity, and inclusion benchmarks. And you can see this in your materials on page 228. The measure that is listed as inactive, and you'll see that at the top there, is about posting our EDI commitment statement online. And you're going to hear shortly from Nizar about that piece. A large part of what it means to build EDI into our operations is governance. And as I mentioned, council and committee members have participated in a number of training opportunities, both generally and committee-specific training, tying EDI principles into the work that you do on your committees on behalf of the college to support your conversations, decision-making, and awareness. And our governance committee recently worked through a managing bias training for recruitment and had excellent discussions to help them prepare for the upcoming election. Having an understanding of the diverse identities in our governance was also a piece of the work that the governance committee undertook this year. You'll see in your package in the appendix, there are some charts related to council and committee demographic data. And I'm not going to go through all of it for the sake of time today, but under the leadership of Laura Thacker, council and committees were provided with a voluntary diversity self-identification questionnaire. Now, this demographic data helps us to provide a snapshot to help us enhance our onboarding and training, identify gaps and perspectives not presently in decision-making. As a caution, the goal is not to check a box. In fact, nothing that we are doing is to check a box. It's to allow us to examine our governance and reflect on the public that we serve and the voices that we should be hearing from. Although participation was completely voluntary, we had significant participation from all of you on these questions. So I thank you for your participation. Access to this data is confidential and restricted. And so for your reference, you have aggregate data in your package. I just want to take a look at a couple of points. Here is the data reported related to gender. And you'll see here that the registrant data is taken from the annual renewal data. In terms of the profession, we're looking at a reported data set of about 44% female and 50% male. And this closely reflects the professional member, council members on our council. Our non-council committee members are almost at gender parity. And as it relates to public members, we have 64% of our public members who identify as male. We have quite a bit of diversity when it comes to faiths and beliefs represented around the table, specifically within our now non-council committee, where we see a tremendous amount of diversity of faith backgrounds. Professional members on council tend to be, for the majority, 50 years plus in age, and our public members, for the majority, range about 60 plus in age. More than half of Ontario's dentists are under 50, so we do see more distribution of ages and years of practice in our non-council committee members. Related to cultural backgrounds, we do see the majority of our colleagues who identify themselves as white, European ancestry as the majority background in all three categories of governance. So understanding the diverse perspectives of our decision makers helps us to better provide supports, training, and learning to council and committees. And updated recruitment this year, we've updated some recruitment language for elections, and we are trying to understand the relationship between diversity, equity, inclusion, and good governance. And finally, as I begin to close here, supporting access to care has been an enormous and rewarding part of this EDI work. As Andrea mentioned in her strategic update report, there are several interdepartmental collaborations happening when it comes to access to care. And through the EDI strategic project, we also have been partnering with CE and Susan and team and Michelle Cabrera-Gali and her leadership on access to care. And as a team, we are building relationships with organizations, and those relationships take time and intention. We know that CE offered to dentists through organizations that have specific knowledge of communities will have a greater impact towards providing supportive, safe, equitable, and trauma-informed care. We are so excited that this year we've been able to partner with Special Olympics Ontario, Rainbow Health Ontario just in this past recent days, and we were also able to participate in the Alliance for Healthier Communities Conference last June. And so, as I mentioned in the briefing note, equity work is an ongoing journey of learning, of understanding, and action. This work will continue long after the 2023 to 2025 strategic project ends, and there's lots of work to be done. If there is a message I want to leave with you today, it's that this work is up to all of us, council, committees, staff. While there are many ceremonial and symbolic things we can do and should do on EDI, it's a priority for this team that we make meaningful change. And we will be hearing more about this commitment to EDI and meaningful change from Nazar following this presentation to discuss our organization's commitment statement. The RCDSO has committed this strategic project that I just shared some highlights about to embed EDI into all of our work. And we see this as a very relevant work for a regulator and believe that the public interest is served through these efforts. That concludes my update for today, and I'm happy to stop here and hear any comments or questions you might have. Thank you.
Thank you very much, Michelle, for your comprehensive report. And I am going to look for questions from council, and the first person on my list is Peter.
Thank you, Michelle, for the report. One of the things, I mean, I enjoyed seeing the stats. First time that I've actually seen stats on everything from the staff to the council. What I'd love to see, I'd love to see us take it one step further. I would love to see us kind of break it down, even as far as salaries go and as far as years of experience at the college go. And let's take a look to see if EDI is still applicable in those cases where perhaps we compare men and women. We look at their salaries. You can look at different nationalities, different religions, and see how things break down. That's my comment. Thanks.
Thank you.
Peter.
Nancy?
Thank you, Hanno. Thank you, Michelle, for the update, and your presentation was excellent. I just had a quick question. You talked a little bit about the upcoming learning events. Will council members be able to participate, or will there be a link that we could view a recorded version of the workshop?
Certainly, I can connect with Laura about doing that with council as well. Specifically, the Trans 101 workshop will be recorded and we'll have that available for a few months. And that's something that we can share with you. In relationship to the Working While Black documentary, for copyright reasons, that one will only be hosted in person. But if it's something council finds of interest, we can certainly arrange that for a specific viewing for council.
Thank you. Ron?
Excellent presentation. EDI is progressing very well. One aspect I feel is our council is quite diverse, but we still do not have an Aboriginal representation in our council. Are there any efforts being made to bring some person of Aboriginal background?
Thanks, Ram. I did mention at the end of my presentation there that the language related to elections and recruitment was updated this year. And one of those updates was a specific call out for an Indigenous candidates. Laura could probably speak more to that, and there's way more work to be done. But knowing our data related to the demographics of council, we can use that in order to share, recruit, and request that folks put their name forward. I know that Laura, she may or may not be, I think she's in the room with you, but we can definitely take that away to see what efforts we can make to make that a more an area of focus for a member of council.
Thank you for that response, Michelle. And I don't want to put you on the spot, Laura, but is there anything you wanted to add to what we just heard from Michelle?
Thank you. We did, as Michelle alluded to, update our equity statement in the communications that went out for the call for nominations this year. And we will be doing the same in the call for expressions of interest for non-council committee members. Michelle and I are looking at ways as to how we can potentially reach out to partner organizations to enhance or try and get some Indigenous voice on council and committees. And as Michelle spoke about in her presentation, much of that work involves developing relationships with partner organizations. So that will be an important piece of work for the governance committee in the next year.
Thank you for that response, Laura. And thank you again, Michelle, for your presentation. There are no other speakers on my list. So I would like to move on to the next item, which I realize is going to be an extension of what we have just heard and continues the work with a presentation on an EDI commitment statement. And this item is for council's decision, and we will have time for council members to discuss this. The briefing notes are at pages 224 to 310 of your meeting package, and Council Member Zerladak will lead this conversation. So I'm going to turn it over to you, and please now, Nazaire.
Thank you, Hanno. Laura is going to share a screen on my behalf and be advancing the slide deck that you'll be seeing shortly. So as she does that, I wanted to say good afternoon to everyone. I'm pleased to be before you today on behalf of our governance committee of the RCDSO to present an EDI initiative and a proposal from our governance committee. At the outset, I'd also like to acknowledge my colleagues on the governance committee, Judy Welkowicz, Daniel Haas, Anthony Mayer, and today I'm speaking on behalf of our chair, Ann Coughlin. We are also very expertly supported by Lara Thacker. So Council, today you are being asked to consider and approve a proposed RCDSO equity, diversity, and inclusion commitment statement that Michelle had referenced in her earlier remarks. This item, as Hanno mentioned, is for Council's decision. The draft commitment statement is on page 235 of your agenda package. I know you've read the briefing note, so I won't repeat everything, but will briefly summarize the proposal for you today, and then I'll turn it back to Hanno to present the recommendation in motion and to facilitate any discussion, and I will encourage my governance colleagues to also actively participate in answering in any questions. In the interest of time, I'd ask you to defer any questions until the end of the presentation, and I hope to be quite brief. There are a number of drivers. Slides haven't caught up, so I'll give Laura just a moment. Oh, there they are. Thank you. Thanks, Dan. So colleagues, there are a number of drivers for this EDI initiative that we've just heard about, some of which was in Michelle's previous presentation. In 2021, Council approved guiding principles for governance at the RCDSO, and they're listed on the left-hand side of your screen in terms of the specific drivers, and I'll highlight a few for your consideration or for your attention. Our activity is conducted transparently, reported publicly, and evaluated continuously to improve our effectiveness. We anticipate emerging risks and embrace opportunities for regulatory and governance innovation. And we seek diversity and inclusion among council, committees, and staff, as well as the perspectives of patients and the public, so that our decisions reflect the needs and lived experiences of the communities we serve. Council, words matter. And so I draw your attention to our very conscious wording of the very important concept of lived experiences. Lived experiences is particularly important in an EDI initiative because it refers to the personal knowledge that someone gains from directly being involved in events, rather than from hearing other people's descriptions of those events. In the fall 2023, the Governance Committee determined EDI to be a priority area of focus in the Governance Review and Modernization project that is outlined in our strategic plan. There's been an increasing awareness and a spotlight on systemic racism, and many organizations have symbolically confirmed commitment to truth and reconciliation, anti-racism, and discrimination, and EDI through publishing commitment statements, which you are going to be considering today on behalf of the college. Recent studies have demonstrated the need to combat systemic and interpersonal exclusion and racism within regulatory colleges. In 2024, the Health Profession Regulators of Ontario, HPRO, their anti-racism working group developed the EDI organization self-assessment and action guide that Michelle had outlined for us in the prior presentation. And it was designed to help colleges and with integrating EDI and anti-racism into their work. The HPRO guide contemplates domains and goals in alignment with CMPF. The first governance performance indicator is a public EDI commitment and transparency of actions. In May, RCDSO department leaders were asked to assess the current status of their EDI in their respective areas based on those listed in the CPMF measures. At that time, the development of the public EDI commitment statement had yet to be initiated. We have made tremendous progress since then, and the draft commitment statement is before you today for your consideration and approval. Staff drafted an EDI commitment statement for the RCDSO from the point of view of governance. Now, this is also an important recognition that warrants being highlighted briefly. That is, the staff formed this particular statement that's being brought to council today. And it was them who drafted this statement as our arms and legs into the industry, which harkens to my earlier remarks about lived experience. Last month, the Governance Committee considered and provided comment on the draft language and recommended that the revised statement be brought forward to Council for consideration and approval at today's meeting. And I'll highlight for you that at that meeting, we did not spend a lot of time rewording or redrafting the statement because of our consideration and recognition that it came from staff. But we specifically focused our energies and our attention on matters related to our role as governors and our specific aspect as an employer in ensuring we could fulfill the commitments that are included in that statement. The commitment statement for your consideration is on page 235. Also included in your council package is an environmental scan of other regulatory body who have issued public statements, which the Governance Committee also considered as part of its deliberations. Many colleges' statements were developed prior to the publication of the HPRO guide, and that's helpful context to consider as you review some of those. It is essential for RCDSO's council to set the tone and to publicly signal RCDSO's commitment to EDI to dentists, patients, system partners, and other interested parties. Our collective hope is that we can stand behind our statement and walk the talk. And so as I conclude with regards to next steps, if approved, the RCDSO EDI commitment statement, which I mentioned was on page 235, will be published with any amendments directed by council today during our facilitated discussion and shared on the college's website within a week or so. It will accompany our current content related to our land acknowledgement and our accessibility policy. So in effect, council, building on Michelle's presentation, what we are doing today by endorsing this statement with some modifications and any suggestions you may bring forward will enable us to fulfill our commitment as indicated in HPRO's EDI guide. But as Michelle already very clearly articulated, it's not about checking a box. It's really about the strategic goals of this organization, our commitment to the public, and ultimately to doing what's right. So with that, Hanno, I'll turn it back to you to facilitate any discussion and questions.
Thank you very much. So at this time, I'm looking to see if there are any questions or comments from council. Nancy.
Thanks, Hanno. I endorse the statement. I think it's very powerful. One thing Michelle mentioned at the onset of her presentation, which I found to be very impactful to myself, was that she said every person has value. And so I'm wondering if that particular statement can be weaved into the EDI commitment statement. That's it.
Let me just pull it out in front of me, Nancy. You know what? Speaking just right off the top of my head, I think what you're saying is very valuable. I think what you're indicating, if I'm interpreting your comments correctly, is we all are leaders and we all have a role to play. And so perhaps maybe an elaboration on the second paragraph with the concurrence from obviously Anthony and Daniel, who were here. Judith has sent regrets. But something along the lines of we have a role to play, and maybe building in, we all have a role to play as leaders, because leadership is not a formal title. Leadership is by virtue of your actions. Daniel and Anthony, how do you feel about something like that?
I'm wondering if, Nancy, say that line again that you want to add in.
Every person has value.
Because that sentence by itself is quite powerful. And I agree with you. The second paragraph could be where it would go, and perhaps at the end of that second paragraph. I mean, if everyone obviously feels the same, but I think you've raised an excellent point. I think that sentence on its own is worth putting in and perhaps would go well in the second paragraph. But yeah. I'm open to Anthony. What are your thoughts?
Yeah, I think it's a very powerful statement and it stands by itself.
Yeah, so, we won't wordsmith by committee, but something along the lines of even beginning the paragraph in that regard, because I concur, it's very powerful. Every person has value. We all have a role to play in addressing systemic barriers and historic and something like that. It's very powerful.
I think it's an excellent addition.
Yeah.
Well, thank you. But it's Michelle.
Where would we be without Michelle? We don't want to think about it.
So I'm seeing no other speakers. So then just to clarify, the motion that is going to be brought forward, Nizar, is going to be motion number 4, that council approves the proposed RCDSO EDI commitment statement set out in Appendix B I guess my question of clarification is, and what are we doing with the comments that were just made?
We can, and of course, you're the governance expert, Mr. Chair, but something along the lines of that council approves the draft RCDSO EDI statement as revised and discussed during the meeting with modification, something like that, and approve, because it's really
Okay.
just the one.
Thank you. So if I, oh, Anthony Lisho, your hand is up. So before we entertain. Oh, you were going to move? Noah, did you? Okay, so then if we could have that motion on the screen, please. Motion number 4. So Nizar, I'm going to ask you just to help me out a little bit. So that council approves the draft RCDSO EDI commitment statement as
revised at the meeting?
as revised
Yeah,
at today's meeting.
As revised or amended at the meeting. It's whatever wording is more appropriate.
that works.
As set out in Appendix B and revised at today's meeting. Okay, so that is going to be the motion that's moved by Deborah, seconded by Anthony Lisho. And if I could see the and indicate your approval by your virtual hands up, but I'm going to have from my screen the motion removed so that I can see the virtual hands, please. Okay. And that motion is carried unanimously. Thank you very much. And you may lower your hands. Next on the agenda, the item is about council itself, and council evaluation is a standard in the Ontario Ministry of Health College Performance Management Framework instituted in 2020. This item is for council's decision, and we do have time for some discussion. The briefing notes about this topic are on pages 311 to 313 of your meeting package. And Nizar, I'm going to turn to you again to walk council through this proposal.
Terrific. Thank you, Hanno. So once again, Council, I'm here on behalf of our chair, Ann Coughlin, and our governance committee members. We've had a very active and busy summer. And so once again, I won't repeat the contents of your briefing note. We'll trust that you read them as part of your package. The specific item is also for Council's decision. As council members are aware, in 2020, the Ontario Ministry of Health, as Hanno just mentioned, introduced the College Performance Measurement Framework, CPMF, which we often refer to by its acronym. And it's specifically a tool that all health regulatory colleges with a common set of measures to report how well they are executing their public protection mandate and increase accountability. Council performance evaluation is a CPMF requirement, and the first CPMF standard relates to performance evaluation. We've often heard the phrase, you cannot manage what you cannot measure. It requires that council implement a performance evaluation framework that includes a third-party assessment of council effectiveness at a minimum of every 3 years, and it informs board development based on the results. Next slide. So another important driving force for this work has been the guiding principles of governance at RCDSO, particularly related to transparency, accountability, and continuous improvement. And so another significant driver has also been our strategic plan, specifically the Governance Review and Modernization Strategic Project. And we're paying attention to trends in board performance evaluation and other college practices in order to inform our own. Council, next slide, Laura. Council performance evaluation enables us to assess and report on how well we are executing our statutory mandate and to regulate the profession in the public interest for the purposes of improving performance and increasing accountability. We are of sincere belief that it helps to foster a culture of ongoing reflection and continuous improvement, something that I know is meaningful to all of you in our various conversations. It demonstrates a commitment to our organization's excellence. Performance evaluation also supports the development of ourselves as council members and as the council as a whole. It strengthens our decision-making capacity and our oversight. You know, council, with privilege comes responsibility. Professional regulation is a privilege, and it is our privilege to serve on council. Moreover, the values of the RCDSO, which we have committed to fulfill, and we are reminded of at every single meeting, every single council meeting, that we stand for accountability, collaboration, innovation, inclusiveness, and transparency. So as we prepare for our second cycle of third-party administered council performance evaluation, I urge my fellow council members to use this time to reflect on opportunities for improvement, not only for yourselves, but for the board as a whole, to strengthen our capacity for public protection, our mandate, and to enable us to continue to demonstrate leadership and innovation in our governance modernization. Next slide, Laura. So for those of you who were not on council or present during the November 2021 council meeting, I'll briefly describe RCDSO's the results of our first third-party administered council performance evaluation. In our first CPMF submission in 2020, RCDSO committed to developing a framework for performance evaluation of council and its members. The college got to work quickly, and in 2021, engaging Satori Consulting Incorporated, we developed a customized performance evaluation framework that was approved by the Governance Working Group and Council. The framework was implemented between November 2021 and January 2022, and it included the following: council self and peer evaluation, overall council effectiveness evaluation, committee chair and council president evaluation, confidential debrief sessions with individual council members, and a debrief meeting with council to create a council-level action plan. Your collective feedback from the last evaluation suggested that although council members found the individual debrief sessions to be instructive and valuable, the peer review of all 25 council members proved to be both challenging due to the size of the council and the relatively limited opportunities to observe one and interact with one another and our peers over the course of our term. Next slide. Staff recently conducted an environmental scan of Ontario Health Regulatory Colleges to understand how they are demonstrating compliance with CPMF in order to build on and learn from the various insights from our first experience. Several colleges were found to have engaged third parties, similar to our first effort, in order to conduct governance reviews or targeted evaluations of their council's effectiveness through observing council meetings, reviewing board meeting materials, assessing the extent to which discussions were focused, and advancing our collective mandate for public interest. These reviews typically included the development of a set of recommendations and were presented back to their boards for consideration and approval. The proposed framework for RCDSO's next council evaluation in 2024-25, the next fiscal year, is outlined on this specific slide. Based on our discussions, we are recommending the key components include having a third party observe council meetings, assess meeting materials, and provide council with a report and recommendations very similar to our peer regulating organizations. To facilitate public observations of council meetings with a structured survey, and this could involve members of citizen advisory groups who are observing council meetings, engaging the third-party vendor to potentially administer a survey to council members, and a survey that would include a self-evaluation, an overall council effectiveness evaluation, a committee and chair president evaluation, and a method for the president to evaluate and provide ongoing feedback to individual council members. In other words, retaining the very element from our last evaluation that many of us found quite helpful. This proposal was eventually brought to the Executive Committee for their consideration and feedback in July, and the Executive Committee not only supported this proposal, but committee members remarked that it's vital to the council that it's vital that the council be assessed on executing its mandate and to be seen to be acting in the public interest, and that the new evaluation approach reflects the spirit of continuous improvement. As a result of Exec Committee's review, they proposed to the Governance Committee that we consider the proposal, and we were unanimous in support of this framework. The Governance Committee agreed that the performance evaluation is an expectation of boards, and it's an essential component of our collective board development. External observation, we believe, will ensure the Council is deliberating in an effective way and making decisions in line with our collective mandate. Discussing results publicly also demonstrates the Council's commitment to good governance. Next slide, Lara. So some of the key considerations for the Council are also noted on this slide. Administering the next evaluation midterm around fall 2025 would enable results and feedback to be used to improve the succeeding Council's performance for the remainder of the term. The current modernization proposal includes staggered terms on council, and this means that the schedule for performance evaluation components needs to be reconsidered. That an annual skills inventory, which is also a common practice that most boards will engage in and develop, of our current council will be required to identify the strengths and opportunities for enrichment and to inform the development of the candidate profiles for the next selection. At some point, the Governance Committee and Council will also consider how performance evaluation results can be incorporated into and inform future Council and Committee eligibility and selection processes. So in terms of the next steps, we can go to the next slide, Lara. Regarding implementation, we are looking to council to help determine the appropriate timeframe as to when it should be implemented. And we'd be happy again, once again, with Anthony and Daniel's support to participate in a little facilitated discussion that will be led by Hanno.
Thank you very much for that. So at this point in time, I'm going to look around and see if anyone on council has question, comment. Vivian.
Thank you for the presentation, Lazar. I was wondering, as I was reading about what happened last time with the evaluation, there was peer evaluation. And does it mean that this time there will be just a third party sitting at the meeting and just observing? And what about individual committees? Would there be a third party sitting in the committee as well to evaluate? And there's no peer assessment?
So I'll engage Lara and my colleagues on the Governance Committee to help answer this one. I don't believe that we were going to proceed with a peer-based evaluation because many of us at the time felt it to be a largely onerous activity, and not just from effort, but in terms of truly being able to give constructive feedback to colleagues, because despite us all seeing one another and participating in council meetings, the regular interaction opportunities are just not there. And so many of us felt a little, we were struggling to be able to provide constructive feedback. I don't believe that we were looking specifically for the third party observer to provide individual feedback. I think we were looking more for aggregate level statements around something along the lines of council members felt free to participate. There was a good cross-section of input and discussion that was held. The conversation was not dominated by three vocal minority council members. So I think we'll get collective feedback in that regard. There'll be committee chair and president feedback. The president understood his role as an objective representative and, fulfilled his role. The chair facilitated open and active discussion and, encouraged open dialogue. I also don't believe, but Lara can correct me if I'm wrong, that we were anticipating it going to the level of committee level observation. I think it's exclusively for council, but I stand to be corrected if that's incorrect. Lara's nodding that I think I got it right.
Thank you.
Thank you for that. Mark Eckler.
Well, thank you to you all for excellent work. Fully
support the idea of constant evaluation. My question is, we're going to get feedback based upon third-party observer. What type of accountability or thought has been given to that we are going to incorporate different measures? And are there going to be dates set to make us accountable? Because I think evaluation and data collection is only as good if we use it.
100% agree. I don't think there would be even a remote disagreement. In fact, full support for that statement. I think the report, as we're envisioning it, that we would get back from our third-party observer would be presented transparently at an open council meeting, not privately submitted to the chair or the president or the executive committee. It would be openly presented. And as a result, from that, we would formulate a set of recommendations. Assuming that that report would also come to governance committee, given our recent formation, we're less than a year old as a committee. I imagine that what we would do is take specific recommendations, both those that we feel ought to be continued, so not simply taking a negative viewpoint, but those that are truly constructive and learning how to build upon them, but also, as you just very correctly pointed out, Mark, where there were opportunities for development, incorporating them into our work plan and coming back to the council to say, here's how we think we're going to build upon, learn in terms of our work. And then by virtue of Laura and the team incorporating into work plan, we'd have to build timelines. We'll achieve X, Y, and Z by, A, B, C date kind of thing. And so that's the level of sort of anticipated next steps. Is that a general approximation, Lara? Again, I'm getting good nodded heads. We should quit while I'm ahead, Tara.
Thank you.
That's great, Mark. Thanks.
Osama.
Sorry, I didn't know if you mentioned this already, but what do so this third party, what do we know what type of, and not to get into too many details here, but do we know what type of metrics they're going to use to do this assessment? And it'd be good to know what the metrics are prior, so that there's I've been just thinking, like, it's going to be kind of hard with the size of the group we have. And so it'd be interesting to know what type of metrics they have prior, when they're doing this prior.
Yeah, I can speak somewhat generally, but again, Lara can correct me if I'm wrong, or my colleagues. From my experiences in other boards where this is routinely done, and I'm actually familiar with the company we used previously at RCDSO, Satori Consulting, there's a number of, I would say, boutique and very globally well-known governance firms that will come in, not only providing you with a set of metrics. And so we have our last report to give us some insight into some metrics that I think we had favorable sort of viewpoints on, not favorable results, but as a collective, we liked these measures. And so I see those repeating. Those that I think we felt a little less enthused by, potentially would fall off and be replaced. And there's also, I should say, because we're a public sector body, there's no automatic commitment to go back to Satori. We would probably have to go based on procurement rules to go back to market and procure with another third party, unless we've already actually addressed that and done that. I'm not aware. So typically what they'll do, Osama, is they'll show up with almost like a basket of metrics and indicators and frame them based on their recommendations. Governance committee would review them, take them back to the council to say, here are the performance evaluating metrics, here are the benchmarks, here are comparable data. Because as Mark Eckler sitting beside me had already pointed out, if you have a bunch of results, but you don't know how you compare, what to do with them, what actions you can take, then all you do is have a bunch of results. So it is a systematic process. And the good thing is we're not reinventing the wheel. It's been done for decades. So I'm quite comfortable the governance committee will be able to come back with a fairly robust evaluation framework.
Thank you for that question, Osama, and thank you very much for that answer. And I have no other people on my speakers list, Nazir, so I'm going to take your advice, quit while you're ahead, and I would ask that motion number 5 be put on the screen, please. And motion number 5 for council's consideration is that council approves the proposed council performance evaluation framework for 2024, 2025, That's moved by Mark Eckler, seconded by Ram. Please indicate your approval by raising your virtual hand. And that motion is carried unanimously. Thank you very much. Next item on our agenda flows from the discussion at Council's June 2024 meeting about adding subject matter experts to the Discipline Committee and to the Fitness to Practice Committee. We will now address a proposal to amend the bylaws to add these experts to the hearing committees. The materials for these items are at pages 178 to 188 of your meeting package. The Executive Committee of Council has reviewed this proposal and is recommending it to Council. As this item proposes bylaw amendments, it is for Council's decision, and at the time of voting, it will require 2/3 majority. Jillian Slaughter, Director, Professional Conduct and Regulatory Affairs, will be walking Council through this material. So Jillian, I'm going to turn it over to you now, please.
Thanks very much, Hanno. Hello, Council. It's a pleasure to be here with you today. As Hanno has said, we're here to discuss the bylaw changes to the Discipline Committee and also to the Fitness to Practice Committee. And you can reference the materials starting at page 314. By way of background, on June 20th, Council endorsed a proposal to increase support for the Discipline Committee by appointing subject matter experts who are adjudicators. For the purposes of this discussion, I'm going to refer to them as SME adjudicators. And Council directed that the proposed bylaw changes be brought to this meeting. So I'm just going to advance the slides here. The composition of the Fitness to Practice Committee, however, overlaps with the Discipline Committee. And so to achieve consistency then for both committees, staff are proposing that changes be made to alter the composition of the Fitness to Practice Committee by allowing for the appointment of the same SME adjudicators. And on July 11th, 2024, Executive Committee reviewed the proposed bylaw changes and directed staff to bring those to Council. So today, we're going to be going over the appointment of SME adjudicators to those two hearings committees, which will then change the committee's composition and create a mechanism for compensating then SME adjudicators. Let me show you some data. The graph that you see is sourced from RCDSO's 2023 annual report. The blue line shows the number of hearings between 2019 and 2023. And you can see that the range there is from 8 to 14 hearings per year. For your knowledge, then the number of referrals for those years was similar. In the table below that graph, you can see the number of referrals was 9 in 2023. And to date, there have been 26 referrals in 2024, and more are anticipated this year. The structural changes thus being proposed to you are then being responsive to this significant increase in volume. Let me go through the rationale for the changes. The proposed bylaw changes would offer, 1, a speedy way to achieve timely discipline proceedings. We anticipate that this would result in better service for all parties in the proceedings. It would also allow Council the flexibility to appoint as many SME adjudicators as are needed. The way that the bylaws are being written is that Council would need to appoint at least 1 SME adjudicator to each of Discipline and to Fitness to Practice. It is anticipated, however, that 3 to 5 SME adjudicators would be proposed for the appointment. We are looking for then uniformity here that would affect both committees. The same SME adjudicators thus are being appointed to both committees. That's what's being proposed. Currently, the Discipline Committee is comprised of 14 dentists, 6 council, and 8 non-council. There are 4 public members, with panels typically for contested hearings being comprised of 5 committee members and 3 members for non-contested hearings. When we look then at what are the minimum requirements in the bylaws, the composition specifies that it has to be at least 3 and no more than 5 persons. At least 2 of them have to be public members of council. And at least 1 member has to be both a member of the college and a member of the council. And so you'll see here I've reproduced the college's bylaw 4.41, which specifies that minimum composition of the discipline committee. As I go over the page, you can then see the proposal here is in D in green font to add at least one subject matter expert who has been specifically appointed to chair panels of the committee or assist in adjudicating hearings. When we look then also at the Fitness to Practice Committee, currently it is comprised of 9 dentists with 2 council and 7 non-council members and 2 public members. And when we consider the minimum requirements specified in the bylaws, the Fitness to Practice Committee shall be comprised of at least 3 persons, at least one of whom is a public member of council. Here you also see the text then of the bylaw, which is 4.5.1, that tells you the minimum composition of the Fitness to Practice Committee. And so the proposal that we're putting to you today is adding D, which is at least one subject matter expert who has been specifically appointed to chair panels of the committee or to assist in adjudicating hearings. A few considerations then for council today. Number 1, the chairs of the discipline and the Fitness to Practice committees are supportive of the proposed bylaw changes. If this matter is approved by council, external circulation will not be required. And if this is approved in January of 2025, the Governance Committee and Council would be then asked to likely approve the appointment of 3 to 5 SME adjudicators. As Hanno has rightly said, the vote for this matter requires a 2/3 majority from Council today. For your consideration as well, the competencies for these SME adjudicators have already been prepared and are ready pending Council's decision. As well, recruitment strategies to be able to reach applicants with required expertise and competencies have similarly been developed. So before you today then, and I suggest that we parse this out with, I believe, 2 motions that are going to be put to you, and I'll stop sharing my screen in a moment. Council is being asked then to approve the proposed bylaw changes to add then SME adjudicators to those 2 committees. And Hanno, if I can turn it back to you, please.
Thank you very much. And council, and I do have a little bit of a speakers list already. So Brian, I'm going to start with you.
I was going to end up to vote in favor of the.
Oh, okay. And we'll bring up the motions in a minute, but I do want people to have the opportunity to ask a question if they have it. So Anthony Mayer.
Thank you, Hannah. It was my impression that when we approved adding these SME experts, they were bringing specific skill sets that we did not have all the time with very specific scenarios. But now it seems that they will be there all the time, not just some of the time when their specific skills are needed. Is that correct?
I really appreciate the question. Thank you. Let me speak to it. There would be a change with the addition of the SME adjudicators to these committees. The change would be that they would be bringing legal expertise to the panels, such that then we would no longer be requiring independent legal counsel to be then providing that kind of expertise and assistance to panels throughout the hearing. These SME adjudicators are persons then who would be likely persons with legal backgrounds and also expertise in administrative law. These persons then would be available to the chairs to appoint to the panels. And then they could be appointed to the panel to be a chair or a member of the panel, or could be assisting also with the writing of decisions. So you're absolutely right, Anthony. They are being brought in for specific expertise, which is having an administrative law background, so that they can facilitate the work of the panels.
Thank you.
Thank you for that additional information, Jillian. I don't have any other people on my speakers list. So if I could ask to have motion number 6 put on the screen, and we're going to ask your indulgence, council, because it is a lengthy motion and I will read it into the records. And just so that you realize, the red wording is the proposed change that you are going to be considering. So motion number 6 for council's consideration is that council approves a bylaw amendment to expand the composition of the discipline committee to allow for the possible inclusion of subject matter experts as follows. The discipline committee shall be composed of the following members: A, at least 3 members of council who are members of the college, B, at least 4 public members of council, C, at least 5 non-council committee members, and D, at least 1 subject matter expert who has been specifically appointed to chair panels of the committee or to assist in adjudicating hearings. And that is moved by Brian. That is seconded by Ellie. I'm just going to remind you this would require 2/3 majority, so raise your virtual hand if you're in favor, and please do not lower it until Angie and I have an opportunity to count. Okay, so I've got 19. Okay. 20. Okay, so that then is carried unanimously. Thank you. If you can lower your virtual hand. And now I'm going to ask to have the next motion, which will address fitness to practice, which is motion number 7, put on the screen, please. And again, Council, I'm going to ask your indulgence for motion number 7, that you consider that Council approves a bylaw amendment to expand the composition of the Fitness to Practice Committee as follows. The Fitness to Practice Committee shall be composed of the following members. A, 2 members of council who are members of the college. B, 2 public members of council. C, at least 2 non-council committee members. And D, at least 1 subject matter expert who has been specifically appointed to chair panels of the committee or to assist in adjudicating hearings. And again, raise your virtual hand. Please leave it up because this will also require 2/3 majority. And that's carried unanimously as well. Thank you very much. And thank you, Jillian, for walking us through that. The next item concerns the bylaw change that would allow for a separate compensation structure for the aforementioned subject matter experts. And Jillian, I'm going to turn it back over to you to address this, please.
Thank you, Hannah. Thank you, Council. The related then bylaw changes that we are seeking today speaks to then the compensation. At present, bylaw 10 currently applies to subject matter experts for all committees. Staff propose to remove the application then of bylaw 10 per diems to SME adjudicators. That means that section 10.1.2 of the bylaws would specify that compensation for SME adjudicators would be determined in accordance with an agreement approved by the registrar and each SME adjudicator. For clarity as well, staff are also proposing to change the title of bylaw 10.1.2 to provide clarity. And so let me show you what that's going to look like. And I'll just skip to this slide for a sec. Forgive the large amount of script on the slide here, but you can see the title change is 10.1.2. We're now going to call it compensation and reimbursement for members of the college and subject matter experts. And this bylaw will then be changed to specify first the payment of compensation as opposed to the narrower version of allowances. And it would then have in the paragraph in green at the bottom, I guess, of paragraph 2, it would specify that subject matter experts who are appointed then to the discipline and the fitness to practice committees to chair panels or assist in adjudicating hearings would then be exempted here. Thus, then they would have compensation determined in agreements approved by the registrar. So we anticipate that what would end up happening is that there may be some challenges in finding SME adjudicators with the competencies that we are seeking at the per diem rate specified in bylaw 10. The proposed bylaw then allows the registrar to negotiate those reasonable compensation structures with the SMEs. This would likely be done either on an annual or I guess a biannual, every 2 years basis. And there would be opportunities, of course, for negotiating appropriate and reasonable rates of compensation then for those SME adjudicators. If then the council is willing to approve this, this will then be under the oversight of the registrar to ensure, of course, that any compensation for SME adjudicators is appropriate and commensurate with the type of work that they are doing. So this is now being put to council then to approve this additional bylaw change specific to the compensation for SME adjudicators. And let me take a moment here to just thank Alan Bromstein for his able assistance with this matter, as well as Sinead Earley and Susan Dick, who I know are watching at this moment. Thank you, council. I can take questions.
Thank you very much, Jillian. Now I have some hands up and I'm assuming these are hands for questions. So I've got Amelia, do you have a question? Okay. Anthony Lisho, question? So if you have a question, put your hand up. If you don't have a question, please lower your hand. Ellie, question. Okay. Mark Eckler, question.
Sorry to break the trend. I do have a question. Do you have an idea of the difference on the per diem compensation now to the SME versus what we expect it could be?
The information that I have at present is that I would anticipate that the quantum would be very much akin to what we are currently paying our independent legal counsel. And so for that reason, I do not anticipate that there would be a significant change in any expenses to the college. Because what we would be doing is by having SME adjudicators now on panels as appointed by the chairs of the hearings committees, I anticipate that there would be an expectation or a hope to negotiate comparable, if not slightly different or slightly reduced rates of compensation for those SME adjudicators. I can't tell you what that difference is between the current per diems that we pay for our members to sit on the panels, but I do not anticipate that this is going to result in more significant expenditures different than what we already pay for our independent legal counsel.
Thank you.
Thank you for the question, Mark, and thank you again, Jillian. I have no other speakers on my list, so I would ask that motion number 8 be put on the screen, please. And again, council, bear with me. I do want to read it into the record. So for your consideration, council, motion number 8, that council approves a bylaw amendment to bylaw 10.1.2 as follows. 10.1.2, compensation and reimbursement for members of the college and subject matter experts. The articles of this bylaw related to the payment of compensation and the reimbursement of expenses do not apply to public members of council, but do apply to other members of council, members of the college, and subject matter experts on committees other than subject matter experts who have specifically been appointed to the Discipline and/or Fitness to Practice Committee to chair panels of the committees or to assist in adjudicating hearings. The compensation and reimbursement for each of those subject matter experts shall be determined in accordance with an agreement approved by the registrar between the college and the subject matter expert. And again, I remind you, this would require 2/3 majority. All those in favor, raise your hands and please keep them raised until we do a count. Okay, 19 in favor. Thank you very much. That is carried. The next item on our agenda, council, is item number 17. But before we begin that, I'm going to just take a look around the table. We have about 40 to 45 minutes left in terms of the agenda. It is 2:22. I'm going to look to see if council would like a 5 to 7 minute break. And then I'm seeing lots of in favor for that. So I'm going to suggest it's 2:22. If we could be back at, it's now 2:23, I'm going to suggest we're back at 2:30 and we will continue the rest of the agenda at 2:30. Thank you very much. Please turn your videos off when you leave. what I was doing for those people, unfortunately, who were not hearing, I was just addressing an error that I had made. We now have the mover and the seconder for motion number 7 and motion number 8 are Brian and Vivian. And we just indicated that the motion number 8 was not unanimously approved. There was 1 abstention. So I was just updating that error that I had, those errors that I had made. And now we were moving on to item number 17, which is access to care update. And council has been receiving regular updates on this project. The update for this meeting will focus on foundational research as well as feedback from the Alliance for Healthier Communities Conference, RCDSO Connect session, both held in June 2024. And the briefing notes for this part is on pages 330 to 338 in your meeting package. And this item is for council's information, and we will have some time for council members to discuss. And Michelle Corbero-Gali, Senior Policy Analyst, will lead off this conversation with a presentation. And Michelle, I'm going to turn it over to you now, please.
Thank you very much, Hanno. And I'm just getting my slides up. Okay, so I trust that you can see them. Yes?
Yes, we can.
Okay, wonderful. Thank you so much. Okay, so I'm pleased to be here to provide you with some key highlights from the briefing materials you have before you. And by way of reminder, our focus this year and also leading into next is on professional expectations. So the development of the 2 documents here in the triangle, and then also collaboration and engagement. And you'll see the various consultation and engagement strategies that we're using to help inform the development of these 2 new documents in the circle on the right here. So in terms of the update from the working group, you'll see in your materials that they have met several times so far this year, and they have considered the foundational research that has been conducted, and that includes the literature review, jurisdictional reviews, the RCDSO data, the consultation feedback from the survey we conducted earlier this year, and then other outreach and consultation feedback we received. In terms of council, at your last meeting in June, you received a comprehensive consultation report. And this report is also available on our Access to Care Initiatives webpage for your reference, should you ever need to look at it again in the future. And then in your materials today, you'll see highlights of the foundational research that the working group has considered, in addition to some feedback from the 2 outreach events we held in June. And I just want to emphasize the point that the materials that are before you today are really a high-level version of what the working group has seen. So they have the comprehensive reports with all the references, and they have those for their work in terms of developing the 2 documents. So now turning to the literature review, what we learned from the literature is that access to care is a multidimensional concept. And the most common way to describe access is the 5 A's, which you'll see on the left here. And then another key element of access is also equity. And what we often see in the research is that affordability is one of the key barriers that prevents patients from accessing oral health care. And generally speaking, those who do not have insurance have the most difficulty accessing care, and in turn have poor oral health and overall health. And then looking at the research as well, we see that there are health inequities and inequalities in Ontario, in Canada, and globally. So these patient populations on the screen here have the most difficulty accessing care, and in turn have poor oral health care, poor oral health. So we also looked in terms of the literature at professionalism, and I want to highlight for you some of the key findings on moral inclusiveness. And this research was actually led by Dr. Bonnie Yu, who is an RCDSO staff dentist. So you'll see here that one of the key findings is that the breadth of dentists' moral inclusiveness, which is the extent of people that we would apply moral values, rules, and considerations of fairness towards is influenced by business or financial factors. And then dentists exhibiting moral exclusion, so that is not applying moral values, rules, and considerations of fairness to others, are less likely to treat individuals who rely on social assistance. And then what we learn from the research in terms of patients and their experience in the healthcare system accessing dental care who are on social assistance is that they have challenges accessing the care. And some patients on social assistance have also reported experiencing non-welcoming attitudes and discriminatory practices from dental professionals. And some dentists have negative views and biases about patients who receive social assistance. So now turning to the jurisdictional reviews that were conducted. So I won't go through and highlight every single regulator that we reviewed, but we did look at international regulators, including some international dental regulators who you'll see on the left-hand side of the slide here. We also looked at all Canadian Canadian dental regulators, Ontario health regulators, and then we also looked at a number of associations. So they included dental associations and also some medical associations. And so what we looked at were the professionalism documents that other regulators and associations have. And what we found was that the majority do have some sort of professionalism document. Generally speaking, they're typically called codes of ethics or codes of conduct. And then we also noticed that there were some commonalities in terms of the principles and the values that they articulate. So I've listed here the most common principles and values, and they include accountability, beneficence, competence, integrity, non-maleficence, patient autonomy, and trustworthiness. And then we noted that there were a wide range of duties that were included in these professionalism documents. And I've included some examples in your materials, but they are things like consent to treatment, protection of patient privacy and confidentiality, records requirements. So these are some of the duties that were included in those documents. And then we also noted that some of the documents address equity, diversity, and inclusion. So we noted that these expectations were not reflected in any of the Canadian dental regulators' professionalism documents, but they were in some international dental regulators' professionalism documents and some Ontario Health College documents as well. So now turning to accepting new patients. So we looked at regulators and associations that set out either expectations or guidance on accepting patients into practices. So that's what we mean by accepting new patients. And what we found was that there were some regulators that had incorporated a few provisions regarding accepting new patients in their professionalism documents. And then there were some regulators that had standalone documents or policies or standards on accepting new patients. And we tend to see that more in the medical regulators. We found that most of these documents that addressed accepting new patients prohibited discrimination. And then we also found some common factors that were included in these documents in terms of what providers should be considering when they're accepting new patients into their practice. So they included these three. So whether the provider has the competence to treat the person, whether the care that the person is seeking is within the provider's scope of practice. And then the third most common factor to consider was patient need. So if the patient was in urgent need of care, then the provider would be able to prioritize accepting them into their practice. And then some of the key themes that arose out of the dental regulators' guidance on this issue was that some of them addressed the rights of dentists. And rights is in quotations there because we don't believe they're tied to any legal rights. But some regulators, some dental regulators say that dentists have the right to choose who they want to treat. And then on the other hand, some dental regulators say that patients have the right to choose their provider. And then the other key theme that arose amongst dental regulators was requirements to treat in emergencies. So if the provider, so if the dentist is not available themselves, then they would need to make arrangements or direct the patient or person where to go. So now I'm going to turn briefly to the outreach events. So I think you've heard a little bit about these outreach events in both Dan and Michelle's remarks, but I wanted to note that a summary in your materials have been included in regards to the feedback we heard at these two events on pages 336 and 337 of your briefing materials. So the first event that we attended in early June was the Alliance for Healthier Communities Conference, and we did present a poster there. And then the second being the RCDSO Connect event in London. And the key themes or the key pieces of feedback that we took away from both of these events were that, it's very clear from the participants who attended these events that equitable access to oral health care is a significant issue in Ontario. We also heard at these events a lot of really good examples of what dentists are currently doing to improve access to oral health care, and also looking at what they're doing to improve the overall oral health of the community. And then we also heard about challenges that patients and dentists are experiencing in their communities. So as I said, there is a more detailed overview of exactly what we heard at those two events in your materials, and the working group has received the full report of the feedback and is considering it. So I just want to take a moment to talk about next steps, and Andrea alluded to one of the next steps that we're currently undertaking, and that is public polling. So we're working with a public polling firm to develop a survey on issues related to this project. And we're looking at having that survey completed by the end of this year. So we'll share those results with you and of course the working group when we receive them. And then we're also looking at striking an advisory group to provide information and advice to the working group on this work. And we're looking at consulting with them in this fall and towards the end of this year as well. The working group has a number of meetings scheduled in the fall and winter, and our goal is to bring you a draft documents in spring of next year. So you'll have an opportunity to review and provide feedback on them with the aim of releasing them out for external consultation and then reviewing the feedback, revising them, and bringing you potentially draft documents for final approval by the end of next year. So those are the proposed next steps. And that is everything I wanted to highlight for you this afternoon, but I'll turn it back over to Hanno if you have any questions or comments about the project. Thank you.
Thank you very much, Michelle. Osama.
Thank you. Thank you for the overview. It's a good, clean presentation. I would like to see some more data on the vulnerable populations and what statistics around appointment cancellations, why they cancel appointments, and how we could potentially kind of bridge the gap for those patients. And I speak from experience because we do see a greater number of cancellations from patients who come from more vulnerable backgrounds, and so we want to know why specifically, and so statistics around that first, and then really kind of what are the different solutions so we can help those patients.
Sure. And I do think, so the research does reflect that. So one of the reasons why, dentists may not be as willing or have certain views about patients, for example, who are low income or rely on social assistance, is difficulty in scheduling. So that is reported in the research. You're not the only one to note that. It's reported that this is an issue that dentists have reported experiencing. And in terms of why or solutions, I'll have to take another look to see if the research would provide any insight into that. And I think it's something that we can take back and consider as we work on these two documents.
Thanks, Osama, and thank you, Michelle, for that.
Thank you.
I have no other speakers. So at this point in time, I would like to move on to the next item on the agenda, which is also related to access to care. Health Canada has created a grants and contributions program called the Oral Health Access Fund. It is designed to build on the Canada Dental Care Plan. The details are available in your package from pages 339 to 340, and this item is for your information. And I'm going to ask Dan to talk to you about this item. Dan.
Thank you. I'll speak to it very briefly. You've read the materials. I want to make a connection back to what we heard this morning from NOHA in terms of the National Oral Health Research Strategy, all of the work that you've heard today within our own strategic plan around access to care, and this, this commitment to be a partner in the system and to look for ways that we are partnering and also accessing different funding sources. So the federal government has created this pot of money that goes along with CDCP that is available for specific initiatives. And you saw that there are two streams. We are partnering with Western on one of the streams for the creation of educational programs around social responsibility for practicing dentists. We are also leading on a proposal in the second stream, which is looking at how to provide supportive practices for internationally trained dentists as they are on the path to licensure through the equivalency process or another means, and also at the same time providing resources within dental practices, within the offices, within the clinical practices, in areas of need. So focusing on what would those areas of need be? How do we find, to the earlier point from Dr. Solomon, how do we find criteria that would define an area of need? Is it northern? Is it within big cities for practices that are located within marginalized communities? So that would be the purpose of the development and the submission of the funding. There's no guarantee for this funding. The Stream 2 will work, as you saw, by the expression of interest that's been created. And then I had hoped to hear by today, but we might hear by the end of September, whether we will be asked to proceed with a full proposal. So if we are not successful, we are also actively exploring whether there are other alternative sources of funding and whether we can do this project with internal capacity or how we would budget for that. So more to come, but I wanted you to just be aware that this is part of this bigger strategy around access, around EDI, and really an integration of a lot of the work that we're already engaged with. So I'll stop there and take any questions, but it is still an early stage and I don't have any information about what the next steps might be.
Thanks, Dan. Daniel Haas.
Thanks very much for the explanation. A quick question on the ITD plan. Actually, there's two parts to the question. And just based on reading, it sounds as if it won't be all acts of dentistry that the ITDs will be conducting, or will it? In other words, what parts of dentistry will they be doing under supervision? And the second part of my question is, how will the patients know they're being treated by a non-certified dentist?
So in terms of the first question, I think some of our partner dental regulatory authorities across the country, Alberta specifically, are looking at this kind of a proposal within their jurisdiction. And the term that's used is the non-irreversible acts or treatments or procedures. that individuals who are on this pathway would be enabled to or authorized to perform. We still have to work that out. But it really is, it's trying to make sure that there is a rigorous supervision program in place. And that would be the dental clinic, not just the dentist who's there. So really trying to imagine this as the dental clinic taking ownership of this. So ensuring that the practitioner is safe, ensuring that they're only involved in procedures that are going to have supervision that goes along with it. So more to work out on that, but that's definitely a part of the development process. And then your second point about what patients will know, again, we have to develop that and sort that out. But I think in this world of transparency, you would want to make sure, and I think I would liken this to teaching hospitals, that it's very apparent to patients that when you go to a teaching hospital, you will be seen by residents and you will be seen by attending physicians. And so we'll have to figure out what that looks like, but that is a part of it.
Because that was kind of my question. At a dental school, if you go to Western or Toronto, they know they'll be treated by students. It's a given. If I walk into your office at a location, how will I know that your dental office has non-certified dentists? And I guess that was kind of the question. So there would have to be, the public would need to know this is what they're
Yeah,
saying.
and I think that this was why the concept that was developed, that was shopped to a few people, is based on the dental clinic. So normally we talk about a dentist as a supervisor. This would be the dental clinic taking ownership of that experience, so that all of the individuals working in the clinic would have full knowledge of how the clinic is working with the internationally trained dentist, and what that will look like and who's responsible for what.
And the registered dentists involved there would be calibrated, I'm assuming, to be supervisors as.
Yes, and we've developed already a lot of resource tools around supervision within the college for work that happens out of our investigative area already, for work that was developed from the emergency class of certificate. So we'll be able to repurpose those tools, and the dentist and their team would have training options available, and money that would come if successful would be to develop those tools and training.
And when you said non-irreversible, so you're ruling out surgery, operative dentistry, it would be examinations, perhaps scaling, hygiene. Is that what you're thinking?
It could be, yes, but that's still to be developed.
Okay, thank you. That's helpful.
Thank you. Anthony Mayer?
Thank you, Hannah. I just want to go on record as being very supportive of the second initiative in general. I think it's an excellent idea, concept. I just want to caution that oftentimes these kinds of things end up being financial boondoggles. So while we are not there yet, we're definitely going to have to be cautious that the resources are appropriately allocated and not squandered.
Totally agree. I have been involved in a number of projects that have received external funding, including government. We will be, if asked to proceed, we are already looking to work with somebody who will help to develop a full proposal around this with much more detail than we were able to put into the expression of interest, including the budget and what that will go towards. And then there will be accountabilities within if we were the successful group to receive funding.
Thank you. No other speakers on my list. So our last item on the agenda for discussion, Council, is an update from the Health Profession Regulators of Ontario, commonly known as HPRO. HPRO advocates for ongoing regulatory improvements that supports the public interest. The items for this agenda item can be found on pages 343 to 350 in your package, and this is for Council's information. Dan is the chair of the management committee of HPRO, and I'm going to ask Dan to make a few remarks.
Thank you, and I'll also be brief on this. I really wanted to just start to help raise the profile of HPRO. I want you as a council to know that there is this group that is working hard on behalf of all regulators to make sure that regulatory bodies are providing the kind of effectiveness and excellence that we are charged to do with our respective legislation. And for HPRO, This is a membership-based organization, and we have a lot of our staff at the college who are involved in various aspects of HPRO. As an example, Michelle Tremblay is the lead of the network for EDI within all the 26 colleges. We have communications participation on the communications group. We have investigations involved. So there's so many parts of the college that are involved in this very significant provincial organization. And there is probably a 3 or 4 times a year newsletter that I'll commit to bringing as an information item in your package of materials that you can read on your own time. That's all I need to say about it.
Thanks, Dan. Any questions for Dan on that? Peter?
Thank you, Dan. Did I read that you had a meeting with the premier and one of the deputies there? And as an HPRO meeting?
So I'm going to turn it over to Harinder in a moment. HPRO had a meeting with the Minister of Health.
Yeah. That's what I meant.
HPRO invited the minister to our annual meeting back in June. The minister graciously attended, provided remarks, talked about the ministry and the government's priorities around access to care, and was quite complimentary to the work that the regulators are doing. So that was that meeting.
Thank you, Dan. What was the question?
Yeah, I'm just wondering if the meeting with the minister brought on any.
So all the oral health regulators met the premier and the health minister back in May, 10th of May, and discussed the access to care and shortages of staff around the province and how we can alleviate these shortages. All the colleges presented their viewpoints, and there is follow-up work is being planned, and talk to them again and bring some new proposals. And one of the things which Dan has already talked about, provisional licensing for ITDs. That is one of the initiative I think will be presented to them. And actually, Dan has already spoken with the Ministry of Health about it, Fairness Commissioner, and I think they are very supportive of these initiatives. Thank you. And before we go to the council meetings and the motion for adjournment, so for HPRO was concerned, Dan mentioned, and Dan, I want to acknowledge your leadership. It is your leadership which is very visible. You are the chair of the group, and many people from the staff are leading these different sections. So thank you so much for your leadership. And also I want to thank the council for a very collaborative, cooperative, and respectful meeting today, and the staff, IT staff, which the meeting was flawless, and of course our chair for running the meeting so well. Thank you, Hanno. And have a great evening, and we'll, I guess, entertain the next motion.
Thank you, Harinder. Last item on the agenda is for council's information, and on page 351 of your package, you will see the remainder of the meeting dates, or no, I shouldn't say the remainder, the meeting dates for 2025. A reminder that our next council meeting will be on Thursday, October 24th from 9 to 1, and that will be a virtual meeting. I would also like to echo Harinder's remarks and thank council for a very productive meeting and for the time and the effort you put into your preparation as well as discussion. And I also want to specific shout out to staff, the staff who are here, as well as many of the staff whose faces are not here. The work that you do in supporting members of council and supporting me, the work that you do to make sure that these meetings run as smoothly and as flawlessly as they do, and the work that you do in helping with all the positive outcomes from council meeting is certainly very much appreciated. So thank you for that. And my final and I'll try to remember to make sure I get a mover for this, is a mover to adjourn the meeting. Noah, could I have a seconder? Anthony Lisho, and all those in favor of adjourning our meeting. And that motion is carried. Thank you all and safe travels back home.
Thank you.
I'm sorry, I made the assumption. Are any abstentions? Okay. One opposed.
Bye, everybody.